to dignitaries. A very good evening and warm welcome to dignitaries and delegates. Welcome to this important FOGSI ICOG online certification course on breastfeeding in collaboration with Study on Female Breast Committee, FOGSI, with BFHI and KMC of India. So I'd like to again welcome and thank our very honorable President, Dr. Jaideep Tank, FOGSI, and Dr. Parul Kotlawala, Chairperson ICOG, Dr. Madhuri Patel, Secretary General FOGSI, Dr. Sheila Mane, Vice Chairperson ICOG. Dr. Sheila Mane will be joining us soon. And Dr. Sarita Bhale Rao, Secretary ICOG. She's also held up somewhere, but she'll be joining us very soon. Chairperson-elect ICOG, Dr. Parag Biniwale, Dr. Sharmila Ayavu, Vice President FOGSI and ICOG, Dr. Kartike Bhagat, who's the past president and on board with AFG. He and Dr. Charulata and Dr. Parag have been instrumental in putting this together. Dr. Charulata Bapai, a good friend and chairperson study on female breast committee, and Dr. Parag Dagle, who's also the BF coordinator and trustee, KMC Foundation of India, are the coordinators, are the conveners for this ICOG course. And we shall now, Dr. Sheila Mane, are you there, ma'am?
No, Dr. Sheila is not joining today just now. I think Dr. Charulata, you're going ahead with the welcome.
I shall. I think I saw Dr. Tushar Kar, sir. So
Yeah.
I would like to take it forth from here. Thank you, Dr. Divya, for those kind words of introduction. And I would really like to thank the ICOG, the entire team, office bearers of ICOG, and of course, our respected president, Dr. Jaideep Tank, for having this FOGSI ICOG online certification course in breastfeeding in the month of August, wherein in the first week of August, we always celebrate the World Breastfeeding Week. Very important topic, very needed by each and every obstetrician, and hence a right choice for an online certification course. Yesterday was a fantastic day, and today amidst us, before I have the recap of yesterday, I think it is my proud privilege and duty to welcome Dr. Tushar Kar, who is our guest for today. And I can see that sir has joined, although he has been busy. Can I have Dr. Tushar Kar's slide, please? Yes. Sir is an MD, MIs, FICOG, FICMCH, Fellowship in Laparoscopic Surgery from the USA, and is the professor and head of the department in SCB Medical College of Cuttack, Odisha. He's been the chairperson of the ICOG 2019-2020, and he has held a number of important positions in ICOG, IAG, as well as in FOGSI. He has been working for the entire organization since a very long time. And so we are indeed blessed to have Dr. Tushar Kar as our guest of honor for before we start today's academic session. Over to you, Dr. Tushar, to kindly bless this webinar.
Thank you very much. Really, it's a pleasure to become the guest and to start the session. And as you have rightly told, today the other side, our department seminar going on fetal aneuploidy, and I am the coincidentally chairperson. But Sarita told me, no, you'll have to come and address something, then go. Actually, at the outset, I must congratulate our ICOG present team under leadership of Parul, Sarita, Parag, and all others people, you see, like including yourself. So all you are doing a fantastic job. First week of August, I remember there's a breastfeeding week. So, and especially for today, the topics you have selected is most important is the counseling for breastfeeding. That is prenatal counseling. That is very, very important. Often we forget that. And there is a neglected entity, breastfeeding for all of us, especially the people, affluent people who never say about how do you prepare for the breastfeeding. That is very nice. And perhaps the subject will be dealt in details. And you have selected rightly this topic. The other things I remember, that regarding the breast, the mastitis, engorged breast, full breast, cracked nipple problem, all these will be dealt very nicely. And you have selected those topics. This must be included in the breast week. And I must congratulate again our FOGSI ICOG for this selecting this course, certificate course for this breastfeeding. And I hope this CME would be very much beneficial to all the practitioners as well as all the obstetrician of our country. And I also expect a lot of interaction after these sessions. And I say all the best for every speaker to deal for this subject. Thank you very much again, Sarita and Parul, for this nice ICOG organization. Thank you very much.
Thank you, Dr. Kar. Thank you for sparing your valuable time and for being with us for this very important evening of ours. Thank you. And I think that yesterday we saw a great beginning to the online certification course, where we had our first speakers, Dr. Sheila Mane, who talked about the evolution of BFHI. And then we had Dr. Parag Dagli, Dr. Prashant Gangal speaking on feeding difficulties and as well as hypoglycemia in the newborn. This was followed by, the breast crawl and initiation post LSCS, breastfeeding post LSCS by Dr. Kartikeya Bhagat. And of course, our very own Dr. Mangala Vani talked about the breast crawl. We had the pre-test and the post-test conducted well, and we had more than 130 delegates who had joined this particular event. And so indeed, it has been a good response to our online certification course on breastfeeding. And so here we are today to talk upon the next important topics, and which are going to be on antenatal counseling, position and attachment, and common problems with the breast, as well as role of the obstetrician in KMC. Before that, I think we will be circulating the pre-test. I hope most of the delegates have joined. And Dr. Kartikeya wants me to make an important announcement for the same before regarding yesterday's events. So, can I have the slide, please? I think there, so anybody who's interested in a free BFHI sensitization program for your maternity home can WhatsApp on Dr. Prashant Gangal's personal number, and, they will get an immediate response regarding the same. Also, the breast crawl video is available on YouTube, and the link has been posted over here. So all interested delegates could do the needful. Probably we shall circulate this to all those who have joined also, or if there's a common group regarding that, we can put up this slide in that particular group. Thank you so much. Can we
Thank
start?
you.
Yeah.
Thank you, Dr. Charulata Bapai. And I would like to say a few words about Dr. Charulata, that she's also co-edited the book on breastfeeding, which is called Liquid Gold, which is available to all of us. And she's also won the Legions of Gynecologists award by FOGSI just very recently, and she's a brilliant person. We would now like to move ahead to the MCQs, the test on MCQ. And for that, I would like to invite Dr. Kartikeya Bhagat to do the needful. Dr. Kartikeya Bhagat is very, what I could make out by yesterday's talk is that he is so full of us telling us how to go ahead with breastfeeding. So we must listen to him. And he's also worked with Dr. Prashant Gangal on the initiation of breastfeeding by breast crawl film, which is there for all of us. The link has just been shared. And he's also the past president and founder member of, and also on the advisory board of the AFG. So over to you, sir, Dr. Kartikeya Bhagat, for the...
Thank you. See, this program has been designed over 3 days. The first day we spoke about the basic program that is based on the breastfeeding by, it's a baby-friendly hospital initiative, which is based on 10 steps to successful breastfeeding. So throughout the 3 days, through 3 days, we'll go through all the 10 steps of baby-friendly hospital initiative. Yesterday, we spoke about step 1, that is the policy. We also spoke about training the staff, and we spoke about the step 4, that is breast crawl. So today's session will be about training, imparting information, and training mothers how to breastfeed. So the actual training, what is to be done, how to position the baby, attachment, and the common problems people face, which will be followed by kangaroo mother care. And tomorrow's session will include the concluding remarks, infections, and the IMS Act and the monitoring and the data system. So before we start today's session, we'll give you the pre-test. And once the session gets over, you'll get the post-test. So you'll get 10 minutes to do the tests. Your time starts now.
So give a couple of minutes for them to
Yes.
scan this. So if you scan this by your mobile camera, you'll find a link over there, a yellow colored link. Click on that and you'll be able to join the MCQs. Or otherwise you could go to the chat box. Otherwise you
Yeah.
could go to the chat box and click on the link. So thank you, delegates. We now, can we move on to our scientific session? Dr. Karthikeyan, sir?
Sure, sure.
All right. So we move on to our first session, which is on antenatal counseling. And we have,
Let's go ahead.
sorry. So I'd like to call upon our chairpersons, our Honorable Dr. Anahita Chauhan, who is the honorary consultant at Saifi Bhatia and St. Elizabeth Hospitals. She's been former professor and unit head State GS Medical College and KEM Hospital, and she's been the immediate past president, Mumbai Obs and Gynae Society. She's also the assistant editor, Journal of Obs and Gynae of India. We'd like to invite Dr. Ramani Devi, ma'am, who is the managing director, Ramakrishnan Medical Center. She's won 10 gold medals during UG and PG periods. She's underwent an IVF training in Tel Aviv, Israel, Harley Street, London Hospital. And she's been a DNB teacher at CSI Mission Hospital for 5 years, and also the winner of the Professor C.S. Dawn Prize. So over to you, Dr. Anahita Chauhan, ma'am, to introduce our speaker, Dr. Swati Temkar.
Thank you. And it gives me great pleasure to be here. I have been associated actually with the Breastfeeding Foundation and a lot of breastfeeding programs for almost 25 years. And it's very apt that Swati Temkar is going to be speaking to us today. She is an excellent lactation consultant. She is attached to the Raheja Hospital, Mahim, Lilabati Hospital, Bandra, as well as doing a lot of work at Sion Hospital. She does a lot of home visits, and I think in the COVID times also, the video consultations have begun, and she's locally, nationally, and internationally recognized. And she has won the Dr. N.B. Kumta and Navdurga Awards in 2023. Over to you, Swati Temkar.
Hello, everyone. Good evening. And thank you, madam, for a kind introduction. So I will just share the screen.
I think you need to put it in slideshow.
Just a minute, madam. Yeah. Is it visible?
Yes.
Yes. Okay. Thank you so much. So today my topic is antenatal session. So what is the importance of antenatal session? Just a minute. Antenatal session for maternity home and for mothers also. So to prepare mother, so here you can see the picture of pregnant mothers, and I'm conducting the antenatal session, keeping the chart in my hand, and the pregnant mothers with their husbands, they are listening to me. So to prepare mother and family members for the breastfeeding. See, prepare mother is why the preparation of breastfeeding is important in antenatal period, because the
Dr. Swati, we can't, oh, sorry.
yes, madam.
No, nothing. Sorry. I'm extremely sorry.
I'm
Please.
not audible.
You are.
Okay. Thank you, madam. Yeah. So the preparation is very important because the family member support is very important. And secondly, because the breastfeeding is this is the topic where never get exposure in any school or medical colleges. That's why we need to conduct the antenatal session and to get the mother prepared for this. Then positive approach about the maternity home. Suppose the maternity home is following the good breastfeeding practices, it is very easy for mother to follow the breastfeeding very effectively. It increases the knowledge of the mother as well as the staff and family member, encourages positive breastfeeding practices, and builds good rapport with the staff. Antenatal counseling is mostly the group counseling. So if along with the obstetrician, pediatrician, all the staff nurses and Ayabais. Suppose they attend a session, then mothers builds a good rapport with them, and it is very easy for her during her delivery that to deliver in known people. So the mother will be relaxed and calm. And if the mother is relaxed and calm, that will help her to increase her oxytocin level. So this is the third step from BFHI, a joint WHO UNICEF statement. In UNICEF and WHO prepared a joint statement in 1989, 10 steps for successful breastfeeding. It revised in 2009 and again revised in 2018. So antenatal counseling is the third step. Discuss the importance and management of breastfeeding with pregnant women and their families. So how to conduct the antenatal session? Psychological preparation and getting family ready for the newborn. So physical preparation, do you people feel the physical preparation is necessary? No, because as the pregnancy advances, breast get ready to produce the milk and to feed the baby. But psychological preparation, yes, definitely it is necessary because family support is required. When after the delivery, it takes time for the baby, it takes time to adjust with new things, new people. Baby came in the new world. So if any time when baby cries, सबसे पहले रिएक्शन आ जाता है कि अरे तुम्हारा दूध पूरा नहीं पड़ रहा है. So if mother-in-law, I mean mother's mother, mother-in-law and husband, they are aware about the breastfeeding benefits and advantages of benefits, then that will be helpful for the mother. So definitely psychological preparation, and she needs good help after the delivery and support, of course. Then how to conduct the pre-delivery counseling and antenatal counseling. So when to conduct, what should be the content, how to organize the session, what is the difference between antenatal and postnatal counseling and mother support group meeting. So I will discuss each point one by one. So when to conduct the antenatal session, the ideally early third trimester or early start of 7 months. Why not earlier or why not later? Because if we conduct it earlier, mother may likely to forget. And if we conduct in 8 or 9 months, then she may not be able to sit for a longer time to attend a session. Or if mother delivers prematurely, then she may lose the opportunity to attend antenatal counseling. So ideal period to attend to conducting the antenatal session is early start of 7th month. What should be the content in antenatal counseling? IYCN module is prepared by BPNI Maharashtra in collaboration with UNICEF, and Shishu Poshan app is also prepared by BPNI Maharashtra in collaboration with TCS and KEM Hospital. So the complete antenatal session you will find in both the sources, IYCN module. FAQs are there. Chapter 2, part 1 in IYCN module. And if you refer the Shishu Poshan app, it is the heading 1. All 16 FAQs are given in very good sequence. Baby caring practices. Many times the mother-in-law or mother's mother, they are quite aware about the about the bath and how to give massage, whether to put the oil, whether to give the smoke. So these baby caring practices points are very nicely given in the module chapter 2 part 3 and the Shishu Poshan app heading 4. And normal behavior pattern up to 6 months of age, that it takes hardly 5 minutes to convey the points. And this normal behavior pattern is about baby sneezing, then hiccups, everything it is there. In IYCN module, it is appendix 7 and Shishu Poshan app, the heading is 5. So the antenatal session, ideally, the time for antenatal session is 45 minutes to 1 hour. Then how frequently the ANC should be conducted? The frequency depends upon monthly delivery rate. It is the key factor. Suppose the maternity home is small private maternity home and the delivery rate is hardly 15 to 20, then once in a month is good enough. Of course, the space is a crucial issue. I will come to that point later. If the maternity home, it is a private or corporate hospital and the delivery rate is more than 40 or 50, then twice a month, we can conduct it twice a month. And in government setup, whether there is a government institutional hospital where delivery rate is 20 to 30 per day, then we need to conduct it either daily or at least every alternate days. The number of mothers and relatives, but along with the mothers who should attend this session, ideally husband, mother's mother, and mother-in-law. But most of the time, antenatal session conducted in the afternoon hours, so it is difficult for husbands to attend it. So what maternity home can do for husband, they can conduct it on in the early morning on weekdays or any Saturday or Sunday. So all husbands can attend the session. Capacity of the venue is very important, because if suppose the delivery rate is hardly 15 per month, but the hospital is very small, there is no capacity that one mother with along with one relative, so 25-30 people, if there is no capacity that 25-30 people can sit over there, then in that case we need to conduct it twice a month. So conducting antenatal session, it depends upon the monthly delivery rate of the hospital and the capacity of the venue. Attendance is very important. Ideally, the attendance should be 100%. Maternity home should make it compulsory to all mothers to attend this session, but at least 80% attendance is expected. And the staff should enter on the mother's antenatal card about the mother's attendance. So we can say that no mother can deliver without tetanus injection. Similarly, no mother can deliver without attending the antenatal session. So what to keep handy or for to show the demo, what we can use? Breast model and these charts to explain the perfect and deep latch, baby as a doll as a baby, and this is the chart of different positionings. And we can show the shield, but if it is really necessary for any particular mother, so just we have to explain this kind of shield is available for those mothers who need it. What is the difference between antenatal and postnatal session? The major difference is that antenatal is completely on theory based and PNC is completely on practical based. I will just read the points of antenatal and postnatal sessions. So in antenatal session, mothers are very keen to get information. Lot of information can be conveyed. Practical help and practical demos not possible. That's why we have to show it with doll and breast model. And it needs to be conducted 1 to 4 times per month, depending upon the monthly delivery rate. While in postnatal session, mothers are less keen to get information due to tiredness. Only important point can be conveyed, and practical help and demos are possible. And postnatal session required 2 to 3 times a week, depending upon the time of the discharge. Antenatal session can be conducted in group counseling, but nowadays, since last few years, we can conduct as a lactation counselor or as a lactation consultant. We conduct it in one-to-one counseling. I mean, family counseling in lactation OPD in the hospital or home visits. So all family members along with mother, they can attend the session. And rather than in group counseling, the antenatal session, if we take it one-to-one, it's very effective and it gets good impact on mothers as far as breastfeeding is concerned. Less human resources required. Mothers start getting motivated early, and not all mothers attend a session because many mothers are working mothers. So for those mothers, we can give this antenatal session through online by video consultation. In postnatal session, what happened? Both group and individual counseling required. More human resources are required because delivered mother needs food and lot of help after delivery. Mothers get motivated later than required and can be offered to all the mothers. So in village level where mother support group or lactation consultant is not available, so the trained ICDS supervisor or Anganwadi workers, they can plan a meeting once in a month or twice in a month where they can discuss the benefits of breastfeeding. And they can call the lactating mothers over there with their babies. So they are the role model for other pregnant women. So what are the advantages of this session? Pregnant and new mothers can observe and learn attachment and positioning from experienced mothers. They can share their experiences so the pregnant mothers get motivated, and healthy, exclusively breastfed babies can motivate pregnant mothers and lactating mothers to follow the IYCN recommendations. Now coming to the third point, is routine breast examination and preparation is necessary in the antenatal period. So this is the picture of protractility test. Here you can see this is the inverted nipple and this is the protractility test. This test is to be done when the mother has inverted nipple. But very important point, we have to think that baby has to breastfeed and not nipple feed. So baby suckles on teeth means areola and the nipple. So protractility test is not required at all in antenatal period. So this is the picture of inverted nipple, and as I explained, no intervention is required in pregnancy. Now breast shell and nipple shell. Nowadays, no one suggests to use the breast shell because the breast shell has not very useful and it has the side effects of nipple soreness and nipple pain because the shell's holes are not very widened. And rather than using the shells, as I said earlier, as the pregnancy advances, breasts get ready to produce the milk and to breastfeed the baby. But in hardly some mothers, they need nipple shield. If after trying of latching the baby directly, if mother and baby are struggling, then only in that case, we can suggest the nipple shield to specifically for that mother. But only suggesting nipple shield is not good enough, but we need to explain the mother and we need to teach the mother how to use the nipple shield for proper and effective milk transfer so that the baby will have adequate milk transfer while feeding and the mother can get the good weight gain results. So this is Hoffman technique. It was used in very long back. Nowadays, no one suggests. The Hoffman technique is place the thumbs of both hands opposite to each other at the base of the nipple and gently but firmly pull the thumbs away from each other. Do this up and down and sideways. Repeat this exercise twice a day at first, then works up to 5 times a day. Or many mothers, they were doing it 8 to 10 times a day also. You can do this during pregnancy to prepare your nipples as well as after your baby is born in order to draw them. But the now in next slide, we will see, but the research says that doing exercises in pregnancy, I mean, protractility test or Hoffman exercise is not helpful and it is not required in pregnancy. Now here we can say what research says, nipple preparation before pregnancy. So here 3 rows are there, no intervention, shells, use shells, and third group did exercises. And here the possibility is given in the column. So what is the conclusion? So the result of improving nipple anatomy is more when there was no intervention. On the other hand, it is less in who use the second, it is less in second and third group who use the shells and did exercises. Then breastfeeding rates at 6 weeks were very less when the use in shells group, and there was no difference in exercises. So shells are really not effective, and the side effects are more in shells. As I said earlier, the shells has side effects of nipple soreness because of the shells holes are very small. So nipple pregnancy before nipple preparation before pregnancy, what the research too says, if breasts are normal in pregnancy and no comment on it, then mother may get confused. Suppose obstetrician finds that mother's breasts are normal and he doesn't say anything, then mother may get confused and she may get confused whether there is any problem. If obstetrician finds the nipples are inverted and if he convey it to mother, then that reduces the mother's confidence. So nipple protractility improves around the time of the delivery. So during pregnancy or before pregnancy, no intervention is required. And rather than interfering in the antenatal period for protracting the nipple, it is very important to guide the mother to attach the baby on the breast and teach her proper attachment in early postpartum days. So attaching the baby to the breast in the early days is more effective than antenatal counseling interventions. So hence, what is the conclusion of the research? Breast shells or Hoffman's exercise are not useful due to lack of benefits and possible side effects. And routine breast examination is not indicated because it reduces mother's confidence, and there is no useful antenatal intervention for non-protractile or retracted nipples. Now, breast anatomy and relevance of breast size. See, here are the different sizes of breast. Here, this photo, you can see the asymmetric breast, very huge breast. Here you can see the large breast with accessory nipple. This is the side section of the breast, and I don't have to explain this slide for the crowd like you. But what these slides explain, the message from this slide is the breast, most of the time, mother would not, sorry.
Your time is up, ma'am.
Okay, madam. So should I stop?
Finish it.
No, ma'am, you can continue.
Okay.
Finish
Okay.
it.
I will take it fast. So the breast size, milk production doesn't depend upon the breast size. That is the key message from this side. And the last is very easy point, but very important point, suitable clothes. If the clothes are suitable, then mother can breastfeed the baby very easily. So this type of clothes, side chain gowns or side chain nighties are not very advisable, and they are useless because baby doesn't get good skin to skin contact with the mother. So what mother can wear? Completely front open dress, night dress, completely front open gown. And the best dress is mother can wear a sari petticoat, so she can tie it loose if she has a pain at incision side, and she can wear a bush shirt, so she can open the shirt. Baby gets skin to skin contact, and the shirt can open fully, so there is no obstruction between the baby and the breast, and baby gets complete access to the breast. And the last slide, where mother can get the help from lactation consultant or counselor from BPNI Maharashtra. Ask every mother, and my kind request to all of you to please download Shishu Poshan app on your Android phone, BPNI Maharashtra childcare book, and go on website of bpnimaharashtra.org. Thank you so much.
Dr. Swati, it was an excellent, very crisp presentation on antenatal counseling for breastfeeding. I
Yes,
think you
thank
have
you.
covered everything.
Thank
And probably the one thing what I would like to add up is
madam.
antenatal breast examination. You said it will be sort of if you do it and make a note of it, but don't tell the patient. Sometimes we come across very badly retracted nipple, and sometimes we do come across some breast lumps like fibroadenomas remain unnoticed during the pregnancy also. Then we can make a note of it in our own antenatal booklet. And again, the counseling, I personally feel the patient, even when she conceives, she should have the attitude towards the breastfeeding. And by 7 months, later than 7 months, maybe she can be taught about the technique of breastfeeding and how to improve the lactation and all those things, and her psychological impact upon the attachment to the baby. All those things can be better off during the late pregnancy. And again, the concept of antenatal and postnatal counseling, I feel you have very well brought about how many sessions you should have it in a smaller hospital and in a larger one setup. And the postnatal counseling is very important. The
Yes,
day
madam.
the patient delivers, the baby should be put over the breast and they should be started. Breastfeeding should be initiated, that helps both the mother and the baby for bonding as well as for to prevention of postpartum hemorrhage. In previously, we were used to do the nipple retraction, putting this syringes and everything.
Yes.
And antenatal, all those things are going to cause precipitate preterm labor. So all those things, I think they are all needed. And in a nutshell, you have covered everything regarding the prenatal counseling of breastfeeding. Thank you, Dr. Swati.
Yes.
Thank you, Swati.
Yes.
I just wanted to add that
Yes,
I agree
madam.
with Ramni Devi that we always examine the breast at least once in the later part of pregnancy. And to say that we should not examine the breast is not correct. So maybe it is not important from the breastfeeding point of view, but for us, it is important to rule out any other issues.
Okay. But can it be
Agreed
possible,
very well,
madam?
madam.
Can I
But-
ask one thing, madam? Can I ask
Yes.
one
Yes.
question? Yeah.
Yes.
Can it be possible if mother, ask any doubt about the breast or nipple, then only obstetrician can assess the breast or nipple?
I think that is quite different to what we have been doing up till now. And I usually assess the breasts at least once in the pregnancy.
Right, what we feel is that if you examine the breast, the mother becomes conscious. So, if you find a problem, that is going to be detrimental to breastfeeding. Now, most of the breasts are going to make milk, and most of the mothers will feed the baby. A retracted nipple or an inverted nipple has no treatment before
I get
the
it. I
woman
get it,
delivers.
Karthik.
So I think it is important, not to make her conscious. But if by chance she complains, say, okay, will you please examine my breast because I feel I have a problem, then we go ahead and examine the breast. But as a routine, I don't think it is a good practice because it's counterproductive to breastfeeding. See, as far as the other issues are concerned, routine examination, all that, which is an expected mother who's going to feed her baby soon. I don't think we should, undermine her confidence. So as that's the reason we say that breast need not be examined so that it becomes counterproductive. I think it depends on the individual obstetrician's rapport with the patient, how close you are with the patient, which will work. But as a routine, we say that breast need not be examined. Okay, let us not say it should not, it need not be examined. I think that's a better way of putting it.
I think it may not be examined from the breastfeeding point of view, but it would be remiss if we did not examine as a part of our general examination.
And you are going to do it
See,
anyway.
we are seeing patients, Karthik, we are seeing patients who are now 35 and 40 who are getting pregnant. We can't rule out breast cancer or anything else.
Point taken, Anita. Point taken. We are talking from the point of view of breastfeeding.
Absolutely.
All right.
Yeah. Very nice presentation, Dr. Swati.
Thank you, madam. And
Thank-
I'm not a doctor, madam. I'm a lactation consultant.
Yeah.
And I always tell my patients when mothers says that my nipples are not firm or they are inverted, then I always ask her, do you say breastfeeding or nipple feeding? Then she says, then no, breastfeeding. Then baby has to breastfeed and not nipple
Yes.
feed. That is the easy way to convey her, convince.
Right.
So
Yeah.
thank you, Swati.
Thank you so much, Dr.
Thank
Thank
you,
you all
Chair.
seniors and thank you Karthik sir for the opportunity.
Thank you, Swati Temkar ma'am. Thank you, chairpersons, for that very important interaction and bringing up the point of whether the breast needs to be examined or not. And I think each to his own, we need to examine the breast, but not from the breastfeeding point of view, and no comments for the breastfeeding. Moving on to our next session, which is on support to breastfeeding, which includes positioning and attachment and breastfeeding problems. And to do the honors, we have chairpersons, Dr. Deepa Banker, Dr. Sadhana Gupta, and Dr. Vidya Thobi, madam. Dr. Deepa Banker is a visiting neonatologist and KMC expert at SVPIMER, Ahmedabad. She's ex-professor and HOD at Srimati NHL Municipality Medical College in Ahmedabad, and she's also a member of the KMC Foundation India and faculty to advanced NRP and master trainer for KMC training. And then we have, it's an honor and privilege to call upon Dr. Sadhana Gupta, madam, who's a gold medalist and a member of the National Academy of Medical Sciences. She's co-chair of SAFOG NCD committee. She's FOGSI representative to SAVOG and the vice president FOGSI 2016. She's won a number of awards, thrice Dr. DC Datta Prize for FOGSI publications, and much more. And then we also would like to, it's an honor and privilege to call upon Dr. Vidya Thobi, madam, who's president KASOGA 23. She's chairperson, Food, Drugs and Medical Surgical Equipment Committee, FOGSI 2020, and the Best Committee FOGSI Award, Dr. Meheru Dara Hansotia Award was given to her committee, and she is ICOG Governing Council member. So over to the chairpersons to introduce our first speaker, who is Dr. Sarita Bhagwat. She's going to talk on positioning and attachment. Over to you, ma'am.
Yeah, thank you. Thank you, Dr. Divya, for kind introduction. I really thank ICOG and especially Parul sir for giving me this privilege to be part of this course. The positioning and attachment is an art of breastfeeding, which makes mother feel comfortable and natural. And to deliver this talk, I invite Dr. Sarita Bhagwat. Dr. Sarita Bhagwat is a practicing homeopathy consultant, and she is an international board certified lactation consultant and mother support group leader for BPNI Maharashtra. She has been a past president, BPNI Maharashtra, and she is a national trainer for infant and young child nutrition. And she is the proud recipient of Dr. N.B. Kumta Award. I welcome Dr. Sarita Bhagwat to deliver a talk on attachment.
Thank you so much, madam, for the kind introduction. Can you hear me? Am I audible well?
Yes, ma'am.
Yes, yeah.
Thank you. Thank you. So at the onset, I would like to thank Dr. Karthik Bhagat and ICOG for giving me this opportunity to interact with such a crowd. Can you share my slides, please?
Just a minute.
Yes. Yes, next, please. Yes. So, as rightly the madam said, it's an art to breastfeed a child, and the most important skill is latching the baby. So, the first point comes is the attachment of the baby to the mother's breast. As you can clearly see in these two pictures, there is a vast difference. In number one, baby has opened the mouth and taken most of the areola inside the mouth. The lower lip is everted and the chin is touching the breast. As opposite to number two, you can see the baby is only sucking at the nipple. The mouth is not wide open, lip is not everted, and the chin is away from the breast. Next, please. So, for what are the signs of a good attachment? Is maximum part of areola is inside baby's mouth. Now, why areola should be inside baby's mouth and not only the nipple? Is most of the milk is stored underneath the areola. So whenever the baby will press the areola, then only the milk will start coming. Nipple is so small, it cannot store the milk. Okay. So now, when we open the mouth, we just see, all of you can open the mouth and see. Ah, say ah. What happens? Ah. We open the lower jaw more widely. So when we have to eat a bigger thing from our mouth, such as, for example, burger or vada pav or a big sandwich, huge sandwich, what do? We open the mouth very wide open and we extend the neck also. And the tongue is situated on the lower side of the mouth. So the attachment is always asymmetrical like this. And not like this, straight. Okay. So the lower part of the black portion of the areola should be more inside baby's mouth and the upper part may be visible. Then, of course, the mouth should be wide open. Baby should be doing ah and not ooh like this. Now, naturally, the tongue comes out down and forward, and that's how the lower lip turns outside. And the chin touches the breast, so automatically there is, you can see a good gap between nose and the breast, and nose does not get blocked. So what happens is, when the baby is wrongly attached, as you can see in the second picture, he'll just do like this and make a noise, and he's telling you chuk chuk chuk, you know, galat hai, galat hai, galat hai. So always wait for the baby to open the mouth wide enough. And when baby does, it will be painful for the mother also. So if it is not painful, baby is also comfortably swallowing. You can see the chin movements also, then the movements at the jaw also. And the cheeks are always full and they are not dimpling. These are all good signs of a good attachment, perfect attachment. So always remember maximum portion. Now the areola size also differs from mother to mother. Some mothers have small circular this thing, or some may have a large size. So we do not say pura jana chahiye andar. Always jada se jada, maximum part of areola inside the baby's mouth. So I think you have got the good points of attachment. We'll move on to the next slide. So now we will talk about baby's position. Can you see me with the baby?
Yes.
So if you, yeah, I'm just holding the baby up so that it is easily available, visible. So mostly what mothers see, no, you keep baby's position only. The next slide. So mostly mothers tend to hold the baby like this. So the baby is facing the ceiling when they are holding the baby before feeding. And then the baby has to turn the neck and feed. This will be very, very uncomfortable for the baby. Whenever we are eating or drinking, our head, neck and back are all in one line. We don't drink like this, right? So we are not going to make the baby turn the neck like this and then feed. So what do? Turn the baby towards mother. It's the simplest way. Now the head, neck and back, or you can see the shoulder joint and hip joint are in one line. So always see that the baby is turned towards mother in any position. We will be talking about many other positions also. So these rules apply to every position. so that there is good skin to skin contact, baby gets warm, mother's oxytocin is reflex is stimulated, and good ejection reflex, good milk flow she gets. Then one line we have already talked, and we have seen mothers only holding the head also. So that is not advisable. Always support the neck, back, and buttocks also, right? So the whole body almost is supported. Now again, pushing on the head is also not advisable, as we can see that if somebody pushes us from behind, we go back, we arch away. So that is also not advised. So always support neck, upper part of the back, and buttocks. Okay. So this is about baby's position. Turn towards mother, good skin to skin contact, head, neck, body all in one line, and they are well supported also. Next. Yes. So which are the feeding reflexes which help the baby? Like rooting reflex will help the baby to find out where to latch on. Something touches here, they surge, they turn around and they open the mouth. Then sucking reflex, something touches the palate, they're going to suck. So they form a teat inside, which is 2/3 of areola and just 1/3 is the nipple. Then when the mouth fills up, the baby will swallow the milk. And lastly, the gag reflex. So mother learns to position the baby and baby learns to take breast. So all these reflexes are going to help the baby for breastfeed. Next, please. Yes. Now we are going to for mother's position. So what should mother do? Mother should sit comfortably with good back support. She should not lean forward also too much and lean backward also too much. Mostly they try to reach the baby because baby is so small. She will try like this, and the shoulder pain, back pain, everything will start. So take a good back support. Then the next thing is, this is a breast model. So you see mothers or most of the staff also telling the mothers to hold their breast like this in a scissors grip. Now what does this do? Now this black portion or the areola, sorry, we are so used to talk to mothers, we use this black portion name for areola. So we are obstructing, our fingers are only obstructing. So baby cannot take much of the areola inside the mouth. Plus they just don't hold, they press also. So what happens? The milk flow is coming from towards the chest, towards the nipple. So it is obstructed also. So it is advisable to hold the breast in a big C, like capital C letter. Just support the breast with 4 fingers and the thumb on the upper side. Just lift it so that the lower portion of the breast is also emptied, right? And now it is not interfering anywhere between the areola also, and it is not obstructing the flow of the milk also. So what mother will do is she'll touch the nipple to the upper lip of the baby. So breast, so as soon as the baby opens the mouth, then immediately put the breast into the mouth. It is easy for the baby to take maximum part of the areola. So just remember that whenever mother is feeding, baby's nose should be pointing towards the nipple. Okay, just remember this mantra, baby's nose pointing towards the nipple. And lastly, but the most important is interact with the baby while feeding. We'll see in the next slide, why do we need, mother needs to interact? Now, while eating or drinking, our brain is always alert. Never we doze off, like, while doing anything else, we can just feel like, like sleeping, but not while eating or drinking. So the brain is most alert. Now, the brain development needs stimulation. And this interacting with the baby, communicating with the baby will give the stimulation for the brain development. So optimal stimulation for baby's mental development. So this is very, very important point for the mother. While feeding or afterwards feeding complementary food also, you should remember whoever is feeding the baby should always interact with the baby. Next, please. Now, as we see in this picture, the picture which is showing the wrong position, she has not taken any back support. See, always, as I told you, the mother tends to go down as the baby is very small. So you can use those nursing pillows or the feeding pillows which are available now in the market. That is the best thing to use also, or any other pillows at home, comfortable, whatever she is using. So one for the back support and one on her lap so that baby comes to her and she does not go to the baby. So bring the baby towards mother. Then you can see a good footrest also given. Most of the time the legs are hanging, So give a good footrest. So these are small things to make the mother comfortable. So if the posture is very comfortable, then there is good blood flow and better milk flow also. And latching becomes comfortable and it is sustained also for a long time. So these are the important points for mother's position. Now we will look at different positions. So the first traditional, or all we call it Jula type or Palna Paddhat, is we are feeding from the side and holding the hand also from the same side. This is called as cradle position. Now what happens is, here the baby's head is not well supported. Some babies are also hyperactive. They go here, there, and it's very difficult for mother to then control baby also. Aage piche, upar niche, kuch nahi kar sakte hain, right? So now we go to the next position where we hold the baby with the opposite hand. See the difference? And one hand is always free to hold the breast. Now the control is in our hand. There is very good support for the baby. So this is called as cross cradle position. So with the same side, cradle, with the opposite side, cross cradle position, right? And we can easily move the baby from one to the other side also in this position. If the baby is cranky on one side and not getting on this side, then we can just make उल्लू बना सकते हैं बच्चे को और उसको पता नहीं चलता है, तो यहाँ से उठा के ऐसे करेंगे तो पता चल जाता है. So this is also useful to change the side also. Okay. So we prefer this cross cradle position, especially for premature babies, because they are or the low birth weight babies, they need a very good support, and mother should have the control over the movements also. So either in modified or cross cradle, it is called as, we give a good support. Don't hold premature or low birth babies like that, so that they bumble like this and they are not supported well at all. So there is good skin to skin contact and we can adjust accordingly. Or a football hold is also good for premature babies. So just a small tip, that this low birth weight babies, they get tired very easily. So they stop, they take pauses, and they have not sufficient energy to draw the milk also all the time. So compression of breast, just pressing the breast in between, just compression of breast in between. After baby pauses for more than 10 seconds, will increase the volume and calorie value of the milk. Next, please. Okay, so this is a clutch or a football hold, like we hold a football. Now in villages or in रोजमर्रा की जिंदगी में हम कहते हैं पानी का मटका कैसे पकड़ते हैं, वैसे बच्चे को पकड़ो, ऐसे मैं बताती हूँ. So simple to understand, So this is a very good hold. So we should always give options for mother, whichever position is comfortable. Some mothers may feel in one position, some may feel in other position. So we'll see what are the situations where football or clutch position will be useful. Next, please. Yeah, so you're right. Always in twins. If there are two babies, mother can feed both the babies together, so that mother gets rest in between. Otherwise, she feeds the first baby, then the second one, the first baby sleeps, the second one wakes up, he demands food, feed, and mother is never relaxing. So it is always useful for twins to feed them simultaneously in football position. Again, after post-cesarean section also, if mother started sitting and we are keeping the pillows and the baby is kicking on the tummy and the stitches are hurting, so it's always easy and comfortable to hold the baby in football position so that stitches and abdominal part is not disturbed. Then very large, hanging, huge breasts. The mother is not able to see also what the baby is doing, and the breast is all coming on baby's face. So it's always useful to hold the baby sideways. She can have a very good view, and plus she can just one more tip is just fold the towel and give the support underneath the breast to lift it, and then feed the baby. So this is the picture. It is useful how it's useful for twin babies. Next. Yes, this is mother had just come out of the recovery room and just drowsy also you can see. So she cannot turn also immediately. One hand IV is also going on. So now grandmother is also comfortably sitting on stool, and the side on which it has to be fed, we keep a pillow to raise baby's height coming to the breast, and we just turn the baby and baby starts latching so well. So this is just post-seizure the position you can see. Now slowly she'll be able to lie down on one side. So side lying position is also very comfortable. You can observe pillows, 2 pillows underneath her head to increase her height so that she can see comfortably what is happening. So baby is also turned towards the mother, and there's a pillow you can see in between the legs also if she feels comfortable, right? So one more tip is, if the mother doesn't sleep straight and keeps her waist a little away, then baby is more nearer to the mother from the buttocks side, and the nose is always clear. So there is a small tip that whenever you are holding the baby, hold the baby closer from the buttock side, so automatically nose is clear. Next, please. So this is a beautiful old painting you can see. So there is a myth, common myth in our society, and we have seen in few hospitals also that they never ever allow mothers to lie down and feed. How is it possible? Right? So sideline position always helps. You can see the pillows underneath mother's head. The height is raised so well that she can interact with the baby also. The other hand, she can hold the baby, or she can just put behind her head also like this, right? So this sideline position helps a lot in various situations, such as we'll see in the next slide. So it gives rest for the mother, not only for cesarean, but the mother had episiotomy, she had pies problem or any perineal tear. So mother gets good rest. It protects baby's ability to self-latch, disabled mother who cannot bear baby's weight, she can always feed in this position. Then the large breast, because the bed supports the breast and she doesn't have to adjust so much. And if there is any history of difficult experience or refusal to breastfeed, right? Now the next, these are the usual which are used. Now these are little different positions, we'll see 2 or 3, such as reclining, reclining, sitting on a reclining chair like that. So especially useful for forceful let down or milk ejection reflex when there is oversupply. So the mother is like this, so automatically the milk flow will be less, and baby is also a little vertical so that she can also swallow very comfortably. So it is good for skin to skin contact and bonding also, even if she is not feeding the baby. Then the koala or the straddle position, where the baby is straddling over the thigh of the mother and head is supported well. So this position is useful in the situations like, next slide. Yes, the babies who have reflux or ear infections or tongue tie and cleft palate, wherever there are oral restrictions, low muscle tone, hip dysplasia, or breast milk oversupply. Next, please. So last slide, dancer hold. Here again, we are holding between the thumb and the index finger and giving support to the baby for low oral tone and Down syndrome. I think I have finished. Last slide. Thank you so much.
Thank you, ma'am, for the wonderful talk and insightful messages for positioning, like baby should be saying ah and not ooh, or, the positioning also, checking the cheeks for that it should not dimple and it should look full. So even for you covered the position also very well, that skin to skin contact and oxytocin, reflex. It helps in milk flow, and it leads to better transfer of milk from breast to baby's stomach. And also a very important point of keeping nose towards nipple, and even smelling the food also increases the appetite of the baby. And very important to important message of interacting while feeding the baby. I think that is the most important message, that brings in more love, emotion, and the let down reflex would be easier. And so wonderfully, ma'am, you described all the positions, and which is a good position for premature baby, which is a good position for mother when she has undergone CS or when she has large breasts. I recently had a baby with the cleft lip, cleft palate, and we practiced this advised straddle position, and the baby was very happy to first time experience the taste of milk, because otherwise this baby have never tasted mother's milk. So it was a wonderful discussion on all the positions, and thank you very much. I'm so happy to see Sushma ma'am. Good evening, ma'am.
Dr. Sadhana Gupta,
Good
madam,
evening.
would you like to comment? Then we move on to our next.
Thank you. First of all, hearty thanks, Dr. Charulata and Divya, and big congratulations for being always on the move for breastfeeding. And we really hope that it will have a great short-term as well as the long impact on our whole country's health as well as the next generation health. So wonderful presentation, Dr. Sarita Bhagwat. It was amazing with a good dummy and that the nipple what you have created, and you were so considerate for maternal comfort, which is somehow in Indian community, as soon as the child is born, we are totally family. Everyone is only thinking for the baby's comfort. So this was wonderful presentation and a very visual presentation of all the positions, be it a mother or be it a baby, and that will have a great like a visual memory and the imprint to all our people who are attending this ICOG certified course, that how they should do in their day-to-day clinical practice. It was really visual as well as the auditory treat to have this presentation, and I think I have learned a lot from this last 15 to 20 minutes. So thank you very much, Dr. Sarita, and we will like to have you at many programs so that you can put this energy and this knowledge with ease to every person. So thank you. And should I, Divya, invite the next speaker? If you
Yes,
allow.
I think Dr. Vidya Thobi madam is not present. So we can move on to the next topic, which is on common problems like full breast, engorgement, mastitis, and abscess. So ma'am, please kindly invite the speaker.
So it is a pleasure to invite Dr. Sushma Malik, who is Board Director, International Lactation Consultant Association and President BPNI Maharashtra. She has been ex-professor emeritus and head pediatrics and neonatology at Nair Hospital, Mumbai, National Breastfeeding Advisor, National Neonatology Forum, Consultant Advisor, Palliative Care Program, and Vice President Neonatology Forum, Bombay. She has a specialization and position on great pediatrics and neonatology, ex-director of the Amrutnam Human Milk Bank, ex-president Mumbai BF Promotion Committee, breastfeeding coordinator.
Ma'am, chodo bas.
Yes,
That's enough.
So we can say that Dr. Sushma Malik is very appropriate person to give this talk, which a obstetrician's issue always, that how we treat full breast engorgement and mastitis and abscess, and contributing to most of the time when the mother leaves the breastfeeding. So we are eager to listen to you, Dr. Sushma, and virtual dice is all yours.
Thank you very much. At the outset, I would like to thank Dr. Karthik, and I would like to thank FOGSI, as well as I would like to thank ICOG for giving me this chance to speak here today. And as the time is very limited, so I will straight off start sharing my slides. Thank you, Sadhna ma'am, for going on reading. Just nothing is really required. I would jump into the lecture. So I will just start sharing. So I would be talking on common breastfeeding, breast problems, because the second part on nipple problems will be done by Dr. Jayant Shah, my colleague. Why isn't this moving? I have no conflict of interest and no funding, and I acknowledge that I practice both the IMS Act India as well as the WHO code of marketing breast milk substitutes. Images have been taken with the help of a lot of my lactation nurses and the mother support counselors in the NICU, in the LR, and in the PNC. I would request humbly from the audience from refraining from clicking photos and copying or reproducing them, as it is a confidentiality issue. So I would be covering on full breast, engorged breast, mastitis, breast abscess, and blocked duct. So at the outset, I'm very thankful to Sarita for having explained, a good position and a good latch is the remedy for all these things, except of course for full breast. But even there, a good position is really going to help out. And so she's really done more than, enough for me to now just tell you all about full breast. So as we know that when the mother delivers, after the second or third day, the mother starts feeling the fullness in her breast because her lactogenesis too has started, and the hormones prolactin and oxytocin are working very well if we give them a lot of support. And the breast just before feeding, they are completely filled with the milk. And we all know that the production of the milk is because of the hormone prolactin, and it is the oxytocin which causes milk ejection. After the full breast, comes a stage if the mother is not doing good positioning or there is not enough help to help her out, especially if she's a primey or if she is a born to an LSCS mother. We very often come across mothers who would, besides these, also get engorged. And what is engorgement? What is the difference between breast engorgement and between a full breast? We will just see in the next few slides. So this picture really shows you that how a mother in the postnatal ward is feeling this engorgement. And you can see that there is a redness over here. I'm sure she's feeling a lot of tightness, and there is redness. The veins are very prominent. And what happens in the engorged breast is that it is overfilled with milk. The skin is stretched, the nipples become shorter and they become stretched because the prolactin is really very active and a lot of milk is coming in. And once the whole breast becomes full of milk, there is a special feedback inhibitor of lactation or fill that will stop the further production. So what will happen is that the milk has got accumulated in the breast and the milk is not flowing because now there is less oxytocin and the letdown is not occurring. So this is a common symptom that we see after 48 hours, and this can really interfere with the good latch and the positioning that the good latch that Sarita explained to us, and the transfer of the milk can get affected. It is usually caused by a lot of vascular flow, which you can see that I had shown you in this image, a lot of increased vascular flow, there is tissue edema, and because of this lactogenesis, again and again, I know I'm repeating on lactogenesis too, that's when the hormonal action is at its maximum, and the baby finds it difficult to really extract the milk. In addition, there's a lot of lymphatic engorgement because of the increase in the milk production, and the mother starts feeling this pain, this discomfort, and the tightness that she gets in her breast. And occasionally some of the mothers may start getting fever, but remember, it's a mild grade fever and it should not be above 101°F. If it is so, then we will require further investigations and we'll have to rule out other complications. So in short, in the engorged breast, they are swollen, they are hard, warm, and tender. And there are two types of engorgements that rarely occur. The ones which occur because of the lactogenesis 2, when the production is really increased and the baby is not taking in much, it typically occurs 3 to 5 days after a normal vaginal delivery. And this could be delayed to about 4 to 5 days or 4 to 6 days in the cases of cesarean section. The secondary engorgement usually occurs when the lactation has got well established, say at 2-3 months, and this occurs because there is a mismatch between what is being produced and what is being removed from the breast. And this could be because of causes of excessive pumping by the mothers, or they are using a breast pump and so excessive pumping, or there is intentional or unintentional change in the feeding intervals. The mother has started working, or the baby has started sleeping more at night, or the infant has been ill, or suddenly there are latch difficulties and incorrect attachments that would lead to this secondary engorgement. So the engorgement would lead to the difficulties in latching, and the more it worsens, there is a high risk of going into mastitis. So here we can see that the engorgement, especially if you look, I don't know if my cursor can show, the mother in the first image, if you see, is so engorged. It is of a different mother, both the photos, and you can see that this engorgement has even reached the tail of Spence, which is the accessory tissue of the extending from the breast. So what is the treatment? So one thing that I would be doing is EBM, that is engorgement, breast abscess, and mastitis. And in all of them, the treatment that you need to remember is EBM. So EBM for EBM, that is express breast milk. How will you express? Whether it's the baby who is the best choice, that the baby, takes in all the milk, or you do hand expression, you have to see that the milk is removed. So the principle for engorged breasts are advocate milk removal and massage. For this, how do you ensure that the mother's milk is removed well? So prior to her feeding, she can gently massage the breast, or even during the breastfeeding session, she should slowly massage her breast. And if the nipples and the areola are also a lot engorged and there is a lot of edema, we use a method called as the reverse pressure softening technique of the nipple. And this helps to reduce the periareolar edema, and it causes softening. So it helps in the latch, and the baby is able to latch well on the nipple and the areola. Also, sometimes the pain may be a lot, and in such patients, non-steroidal anti-inflammatory drugs like ibuprofen can be given to minimize the pain. We also very often, even at our institute, we were using cabbage leaves for 15 to 20 minutes, which are cooled first in the fridge, and they can be applied. And I'll just show you all some photos also. So practice exclusive demand and unrestricted feeding to avoid going into engorgement. Proper attachment is very important, and avoid any prelactal feeds like balkadu and honey and gripe water, etc. So this is the reverse pressure technique that I was talking of, where you place the fingers and thumb at the base of the nipple and press the tissue inside and backwards and hold for a minute. And this really helps to shift the edema and permits better milk flow. So here you can see that before before the mother starts breastfeeding or expressing, she can use little warm fermentation with which easy letdown will occur. And when she gets a lot of pain, she can use these cabbage leaves or cold packs, which can be used. Excuse me. Here you can see a mother who is using these cabbage leaves very much in our own postnatal wards. So what is the difference between a full and an engorged breast? In a full breast, it's hot, heavy, hard, but it is painful, tense, and red in the cases of engorgement. Milk flows easily when there is full breast, and it starts dripping, whereas in engorged breast, the milk does not flow out. And therefore, you require frequent feeding, express the milk, and give rest to the mother and treat her for any pain. If mothers with engorged breasts are not taken care of and their engorgement doesn't settle, it can lead further to mastitis. And what is the definition? It is an inflammation, which you can see very well in this photograph, a reddish wedge-shaped area. And this is an inflammation of the breast, and this may or may not involve a bacterial infection. So it's an inflammation. Usually about 3 to 20% of lactating women can get mastitis, and majority of the cases will present in the first 6 weeks. Again, over here, there is a hot, tender, swollen portion of the breast, which is usually wedge-shaped, and it is associated with fever greater than 38.5 degrees centigrade, chills, flu-like aching, and systemic illness. It's usually unilateral, and usually it is in the upper outer quadrant, though in the previous photo I have shown you in the lower inner quadrant. So the mastitis spectrum, of course, I will not go into details because there have been a lot of changes in this as per the Academy of Breastfeeding Medicine, that is the ABM, which was the latest protocol that was published in 2022, that it is a spectrum of conditions because of ductal inflammation and stromal edema. And they believe that there is a lot of hyperlactation, and there can or may not be dysbiosis. Just in a line, I would tell you all, dysbiosis means disruption of the milk microbiome. And there are a lot, it is a multifactorial, this dysbiosis. It is because of the genetics, the medical condition of the mother, the antibiotics, whether she's using breast pumps, etc. All this causes ductal narrowing, inflammatory mastitis, which can lead to bacterial mastitis and abscess formation. And so they say that mastitis is a complete spectrum. It's not just an entity. So there is, what are the risk factors that lead to mastitis is milk stasis, when the mother is not feeding enough or the baby cannot withdraw enough. There is sudden change in the breast drainage, poor suckling, infant oral anatomy, infrequent feeding, or maybe even cracked and damaged nipples. Too much breast massage, restriction from a very tight bra, and illness in the mother, or there is oversupply and various other causes. So recurrent, usually some mothers may get recurrent or atypical mastitis. I am not going into too much of details of it, as it could be because of inadequate treatment or continued milk stasis. And the atypical ones are usually the secondary candidal infections. usually no investigations are required for mastitis except those who are having recurrent mastitis or hospital-acquired mastitis, or the patient is allergic to the usual antibiotics. And in such cases, we do the milk culture to look for any resistant organisms. So the management consists of basically effective milk removal, supportive measures, and pharmacological management to treat for mastitis. In the effective milk removal, as I said, that we have to encourage the mothers to breastfeed often. If pain is there, treat them for it. Position the baby. Most important, and most breastfeeding problems will get sorted out if good positioning is being given. And then if it doesn't get sorted out, you can look for other causes. Positioning of the infant at the breast, massaging while feeding may help out. Express milk by hand or by pump, and mobilize the fluid drainage from the swollen breast towards the axillary lymph nodes. Give them enough rest, ensure that the mother is eating and drinking well, give good nutrition. And if she can be helped at home, the family can help out to do the other chores instead of her doing everything. Application of heat just before she's going to breastfeed. Otherwise, use cold packs. Always there's a controversy on hot packs and cold packs. So hot packs are used for getting a good letdown, and cold packs are used for reducing the pain and edema. Very simple to remember. Some of the mothers may be very ill and you may need to admit them and give them antibiotics and give them supportive care then. Pharmacological measures for pain, I've already said ibuprofen or even simple paracetamol, though ibuprofen is better and it is safe. You can give, both the drugs are safe while breastfeeding. Conservative management if mild and symptoms are there. If symptoms do not improve beyond 24 hours, then antibiotics appropriately will need to be given, especially common organisms are. If they are penicillinase resistant, Staph aureus, Strep, E. coli, then give them dicloxacillin or flucloxacillin. In rare cases, you may end up with MRSA, which needs to be treated with vancomycin. So the advice for lactation is give them supportive bras, frequent emptying of breast, can feed from the side of the mastitis, and there is no risk to the healthy term baby to continue breastfeeding. Next, if mastitis goes on or is inappropriately treated, some of the mothers will land up with breast abscess. You can see that this mother has a breast abscess and there is pus formation due to localization of infection. It is usually a breast abscess is a localized collection of pus. Symptoms are very similar to that of mastitis. Causes are untreated, congested, or engorged breast, and the usual organism is Staph aureus. A culture from a breast abscess fluid is really helpful for antibiotic sensitivity. What is the treatment for breast abscess? Needle aspirations. Please, only ultrasound guided needle aspirations will cause the resolution in 82 to 97% of the cases. Incision and drainage is only required if there are extremely large abscesses, more than 3 centimeters. Only then is incision drainage done. And should every time be avoided, because in incision and drainage, you will cut off the nerves as well as the milk ducts. Continue during treatment of breastfeeding, management of breast abscess, continue feeding from the unaffected side, and feeding from the affected side will depend where the location of the abscess is. So you can see the surgical drainage that is occurring, and this is with an ultra sound guided needle aspiration, and you can see the pus that is coming out. this is the right person to be treated with needle aspirations, and this is to be avoided, that is incision and drainage. Prevention of mastitis and breast abscess is exclusive demand and unrestricted breastfeeding with correct positioning. And these differences are quite easy to see. Full breast, engorged mastitis and abscess. I just want to tell you all that fever is maximum in the abscesses, pain is maximum in abscesses. And in all the treatment, you will have to do exclusive breastfeeding. I don't know if I had the time. Can I finish my last thing?
Yes.
Okay. So I just wanted to tell you all about block duct versus mastitis. Before I tell you all the differences for this, I will just first tell you all about the block duct. In a block duct, there's retention of milk due to blockage in one or more of the lactiferous ducts, which is shown, which will cause the block duct. This usually occurs when there is tight clothing, tight bras, or pressure when the mothers start using scissoring, inappropriate or improper attachment, large and pendulous breasts, and you can see that the mother is doing a lot of scissoring over here. And the block duct may get infected and cause then infected mastitis. But in block duct, though there is a lump and there's tenderness and localized small area of redness, there's no fever and the mother feels quite well. And what are the causes? I've already actually told. So continue to breastfeed, adopt a different position to breastfeed the baby, and starting from the chest, gently massage the lump towards the nipple to unblock the duct. I think just that slide of the differences which I wanted to tell you all. So there is in block duct a tender red area, there's no fever. In mastitis, there's fever and severe pain. Lump is felt. In mastitis, there is no lump. It's a widespread area and it doesn't get demarcated. Frequent breastfeeding and change in position will help for block duct. Frequent breastfeeding, change in position, but antibiotics, rest, and analgesics would be required. Thank you very much for a patient hearing. Thank you.
Thank you,
I
ma'am.
had to really go on a roller coaster to finish it off.
Thank you for the excellent presentation. I'd like to invite comments from the chairpersons, please.
Thank you, Dr. Sushma. What we can say, simplicity is the ultimate sophistication. And that was your talk. Very simple, very precise, and a very clear picture how to differentiate between engorged breast, full breast, mastitis, and abscess. And here is the issue that how we don't overdo the treatment, and that is the supportive care and of course the preventive thing. I will just like to have your comment that in my practice, sometime when we are a little bit in dilemma, the ultrasound examination with the linear probe, it gives us quite a bit idea, especially when we want to see that it is a abscess and the mastitis. And
Yes.
that can be of great help when we are in certain dilemma. So
Yes.
any comment from you for this, the use of ultrasound in this situation?
Yes, the ultrasound is a very important tool, and not only is it diagnostic, but even therapeutic in the sense that now latest evidence also shows, besides using the ultrasound, not only for diagnosing an abscess, the size, the location, and if there are any septae, it can also, they have tried what is called as low grade ultrasound. They try and massage with, we don't have that facility in India, but in abroad they have tried. And the latest protocol also says that you can use it, for, especially for mastitis, not for breast abscess. So it has a very important role, and we have to use ultrasound guided, needle aspirations for the treatment. Besides doing all for exclusive breastfeeding, latching, positioning, and all that.
Thank you. And the ongoing support, the moral support through these
Yes.
difficult times, because it is more morally disturbing. Patient is psychologically too much disturbed, the
Yes.
failure and the pain, and that psychological support is very, very important. Right.
Yes.
Dr.
You, ma'am.
Deepa, your comment. Yes.
So,
Yeah.
Dr. Deepa Banker, ma'am, sorry to interrupt. There are a few questions if you'd like to take up in the chat box, and any speaker could or you could answer them. Anybody? The first question, should I read out the questions, ma'am? So
Yeah,
the
ma'am.
so the first one is, ma'am, can you show how to reverse pressure technique?
Okay, so in the reverse pressure technique, sorry, I haven't kept the breast model, but just imagine, just put your elbow, just keep your elbow. And if this is the, I can just draw on it. I hope I can. And you all can see if this is the nipple, right? And what you need to do is you have to give a push behind where the nipple and the areola will, especially the areola, at the areolar ridge, you will push it behind. So use your pressure to do it, and do it gently.
Show it sideways. This way.
Show it sideways?
Yes.
How do
yes.
I show it sideways?
Yes,
Sorry
that's
that
right.
I didn't keep
If-
the
Keep the hand.
model. Maybe if you want, I can just show it once again on the slide if it is okay, or there is no time.
There is paucity of time, ma'am, but I
Okay.
think we have understood what you're trying to tell us. It is quite obvious and so nice of you to explain it this way. The next question is how to massage. So would you like to
One
explain
second.
that?
Yeah, why can't I, what's happened to my screen? I can't see all, but I'll just answer. I can't see anyone.
Okay, ma'am.
Okay, so the massage for the breast while you're breastfeeding is, I guess the participant has asked, is in a circular motion with the 4 fingers. Just press on the breast and keep going in all the quadrants slowly while the baby is breastfeeding and suckling. Just massage the breast in all the quadrants. That is what is for massage of the breast.
Divya, you are unmuted. Divya, please do unmute yourself.
So thank you, ma'am. Thank you very much for the explanation.
Thank you. I can't see anything, but it's okay, please. Yes.
No, ma'am, thank you so much. It's all understood very well. Thank you. And we move on to our next topic, which is nipple problems, cracks, flat and retracted nipples, and candidiasis. Madam Deepa Banker, ma'am, could you invite and
Yes.
introduce Dr. Jayan Shah, the speaker?
Yes. Thank you, ma'am. This is a very important issue and a common problem with the breastfeeding. And for this topic, I would like to invite Dr. Jayan Shah. Dr. Jayan Shah is a practicing pediatrician at Nandurbar, Maharashtra for over 32 years of experience. And he is the International Board Certified Lactation Consultant. He has been a chairperson and past secretary of IYCF chapter of IAP and also an EB member. Is a past president of BPNI Maharashtra and faculty for IYCN. He is also a recipient of Dr. N.B. Kumta Awardee for outstanding work in infant and young child nutrition. He's a speaker in International Lactation Conference, iLactation, and has written several chapters for various IYCF books and also involved in national guidelines and speaker at many IYCF conferences, and is also interested in singing, yoga, and Vipassana meditation. We are privileged to have you, sir. Please welcome.
Good evening. Thank you very much. Thank you, Dr. Karthik and ICOG, for this chance to speak with you all. And although this topic, which is very important and common, and there are many different problems which can occur, or the many types of nipples variations are there, and they can cause problems with yes, just a second, I'm adjusting my slides. Okay. So nipple problems, there are many types of nipple problems, and of these, a few are very important, and we will try to discuss only those because we cannot discuss everything in this 20 minutes. So let us start. So what we will discuss today: flat or inverted nipples, cracked nipples, and candidiasis. Breasts and nipples, we all know that they come in various sizes and shapes. That is why we have to first understand what is normal and what is not normal. Because sometimes the normal variation can be there and we may think that this is an abnormal looking nipple. So we have to be careful about it. So let us understand how this nipple develops as an embryologic factor. So during embryologic development, at the level of the nipples, there is an epithelial pit, and it is inside, it is gone inside, inverted, and the future ducts, they open into this. And after that, the underlying tissue proliferates and pushes it out. So this pit goes out and then it makes the nipple. Supposing this epithelial pit does not invert, then it leads to inverted nipple. So this we have to understand as embryologic connection. So now let us discuss flat and inverted nipples. So when you see and think that this is a flat or inverted nipple, how we should approach? So there are various appearances of nipples. Some appear protruding, but they may actually invert when it is compressed. Whereas sometimes it may be other way around, that they appear inverted, but they protrude when they are compressed. So do not rely just on the visual assessment or self-reporting by the mother to judge the protractility of the nipple. The best test is done by the baby while breastfeeding. If the breastfeeding is going on well, there is no need to assess or intervene in that case. Now, some people do nipple pinch test. What is nipple pinch test? The just from the base of the nipple on the areola, about 1 inch on either side, with one side the thumb is there and on the other side the index finger. It is pressed, and by pressing, and you have to see what happens to the nipple. If it protrudes, it means it is protruding. Sometimes it may remain same, or it might sometimes actually invert. Even if all these things happen, you cannot conclusively say that whether just because the nipple is not protruding, the baby will not be able to breastfeed. Because just like Swati also said, that babies breastfeed, not nipple feed. So many times, even with these retracted or inverted or flat nipples, with proper help, they can breastfeed. And hence we should be careful about not making any statements about the mother's nipples in antenatal period or even afterwards, that the nipple is very short, whether it is very flat, retracted, and these things can undermine the mother's confidence. Now with flat nipple, what is when the nipple pinch test is done, the nipple flattens. So this is called a flat nipple. Supposing with nipple pinch test, the nipple actually protrudes, then it is not a flat nipple, and you have to be you should not be doing any intervention for that. However, when it is there, you have to assess the baby, whether the baby is finding any difficulty in latching or there is breast refusal, and obviously we have to be very careful about the latching is proper. Inverted nipple. With nipple pinch test, if the nipple goes inside, it inverts, then it is a inverted nipple. And if apparently inverted nipple on pinching, it protrudes, then again it is not a real inverted nipple and no intervention is required. However, this one point we have to remember is that a nipple that appears inverted, that there can be decreased milk supply from an inverted nipple. Why? Because with inverted nipple, there might be a few milk ducts. Milk ducts might be a little less in number, and also there would be some areolar edema and breast engorgement, and in that case, these few milk ducts are there, and they can also get compressed or blocked. So breast milk supply might become difficult in this case, so we have to be careful about it, and then again assess the baby for proper latch or whether there is any breast refusal. Now, what are the possible causes why flat or inverted nipple occurs? The areola may be non-elastic, so it becomes difficult for the nipple to come out. Engorged areola, that may make the normal protruding nipple flat. If there is engorgement of the areola, it becomes stretched out and the protruding nipple also may be pulled inside. There can be adhesions inside the areola and nipple, and that connects the nipple to the inner tissue. Then it can tug it from inside. Or there might be some history of breast piercing or surgery. These are the possible causes for the inverted or flat nipples, apart from the original embryologic cause. So what do we suggest to the mother? Give suggestions only if this flat or inverted nipple is interfering with breastfeeding. If there is no problem with breastfeeding, do not even mention it. You just carry on. What she can do, she may express some milk initially to reduce the areolar engorgement, to make it soft. Some little milk is removed, and that is why the engorgement is reduced. Just now, Sushma madam has said reverse pressure softening. Reverse pressure softening can also make the edema less on the nipple and areola, and this can temporarily make the protrusion of the nipple, and that can allow the baby to latch onto it. She may try hot or cold fermentation or take warm shower, and she should see what helps her more. There is no certain thing that will help everybody. She can even try out pumping a little just before the breastfeeding, which can help in pulling out the nipple. But excessive pumping is also not recommended. Just before breastfeeding, she can apply her own breast milk to the areola and nipple. By applying the mother's own milk, the areola and nipple can become soft, and that will help the baby to latch onto it properly. She can shape the breast in such a way that the nipple becomes prominent. The breast and areola can be held together between thumb and two fingers, and nipple sandwich can be made. This can help the baby to latch onto it properly. She can try various positions. In some positions, it might be easier for the baby to latch. In some other positions, it might be a little more difficult. So she should give it a try to every different kind of position. And even when in a rare situation, when both nipples are truly inverted, and after all the efforts, latch is really not becoming possible, again, we should not lose hope and continue to motivate the mother. She should express the milk, and that can be fed to the baby with methods other than bottle feeding, by giving either with vati spoon or some other methods. And with some time, as the baby also grows, the latching sometimes becomes possible, even if it is not possible in the very first few days. So we should continue to encourage the mother and continue to try it. Now, there are many other helps that are available in the market, like breast shields, breast shells, nipple everters. They all have some benefits and some risks. So they must be used under supervision of an expert. They should not be used by mother herself, because if the use is not proper, she can even harm herself and the nipple can be damaged more. So all these can be tried only under the supervision of expert. Again, here, some of the mothers may find it helpful, some may not find it helpful. Previously, a syringe use was very common, that inverted syringe, but that has not shown to be of any use, and it can cause damage to the nipple areola complex, and hence that syringe is not now recommended. Even the nipple exercises are found to be of no use, and they may even cause tissue damage if it is done excessively. In pregnancy, about 10% women may have flat looking nipples. But as the pregnancy advances, the hormonal changes are taking place in the mother's body. and that increases the skin elasticity, and nipple protrusion generally occurs by the end of pregnancy in most of the women. And nipple protrusion improves with each pregnancy and with more and more breastfeeding experience. So any prenatal intervention is required, no prenatal intervention is required for this, and they are all proven to be of no use. So what happens with flat or inverted nipple? With good counseling and help, most of the mothers with flat or inverted nipples will be able to breastfeed. So this is one very heartening thing we all know, and we can tell this to the mother. So now let us come to the cracked or sore nipple. Cracked nipples, they lead to irritation and scabbing on and around the nipple, and this can occur either during sports or from breastfeeding, not properly doing. Many mothers face the problem of sore or cracked nipples, especially in the first few weeks. Why it happens? Improper latch and improper positioning, that is improper technique of breastfeeding, or improper use of breast pump, especially if the breast pump flange is too small. Now, why should we be worried about cracked nipples? First, the pain due to sore and cracked nipples is very severe, and it is a very common cause of stopping breastfeeding. So we have to be careful about tackling this. And previously, it was believed that the cause of mastitis was the ascending infection from these cracks. But however, the new understanding about mastitis has changed, just Sushma Madam has told that the understanding has totally changed in the last 2-3 years. So what causes the cracked nipples? In the initial period, when the baby is learning to breastfeed, the baby may take a little longer time to latch, and there might be some friction on the nipple by the baby's mouth, and baby is also trying to understand where to latch properly, and this friction can sensitize the nipple and irritate the nipple. This is one thing. If the nipple is dry because of either the original skin of the mother or because of some applications which has made the nipple dry, then it can lead to cracks and sometimes even bleeding. Or if the mother has given bottle to the baby before starting breastfeeding, then the baby has this nipple confusion. Baby might be trying to suck on the breast like it is sucking on the bottle, and the technique is wrong, and in that case this can cause cracked nipples. The longer the bottle feeding experience, the more chance of trauma to the nipple. So how do we treat or prevent the cracked nipples? Correct the technique of breastfeeding. Correction of position and latching, correction of position and latching, correction of position and latching. This is the most important thing, and most of the times this is only required. Then additionally, some local application of breast milk after feeding, that is the hind milk that has come, that can be applied to the cracks. And why this is useful? Because first, it has good antibacterial properties, and it can also help the nipple and areola makes a little soft. Then some other emollients like lanolin based creams, coconut, etc. Sometimes they can be tried, but in some individuals, they can cause allergy and cause even more problems. So one has to be careful. Mild steroid application for less than 2 weeks is also advocated sometimes. That can be tried. Avoiding using too tight bras, which would increase the friction with the nipple, and avoiding harsh soaps, deodorants, powders that can dry the nipple, because we have seen that drying of the nipple can cause cracks. So now coming to the last point which we are going to discuss today is candidiasis. The candidiasis of nipple and areola. Now recently, even for candidiasis of nipple and areola, the thinking has totally changed. Many researchers think that candidiasis of nipple and areola does not exist. Some say that the most of the time this is a mixed diagnosis. It is either some dermatosis, vasospasm, subacute mastitis, or some pain syndromes which are misdiagnosed as candidiasis. However, it is still not established, and we should understand if there is any real cause. So candidiasis or nipple thrush. This is the fungal infection of the nipple and breast tissue caused by Candida albicans. We all know that. It causes intense pain, itching, and rash. It can be caused by antegrade fungal infection from the cracked nipples and use of antibiotics excessively, which can destroy the friendly bacteria. Friendly bacteria have the capacity to prevent the other infections. They It holds the pathogens from causing the infection. And Candida thrives in dark, moist, and warm environment. This is available in the baby's mouth. And also, if the breasts are always covered, warm weather, perspiration is present, in that case, these Candida can thrive more. So, what are the symptoms of nipple candidiasis? Symptoms generally appear in the first 6 weeks after giving birth. Bright red or pink tinge to the whole nipple. The skin might be shiny, and there is burning or stabbing pain. This stabbing pain is very important. Deep within the breasts during or after breastfeeding. This can also lead to cracked nipples. Dry, flaky skin on the areola. There will be difficulty in breastfeeding. There will be itching. And the last thing is important, that if the breastfeeding has started and there is new kind of pain, or the pain is increasing, then we can suspect that there might be something more that has occurred just recently, and that can be, one of the causes can be candidiasis. At the same time, we see thrush in the baby's mouth. So baby's mouth is usually covered with white coating. It can, the white spots can be on the baby's tongue, on the gums, on the roof of the mouth, inside of the cheeks. And if you try to wipe it out, it cannot be wiped out. The baby will have difficulty in feeding, baby will be crying, there might be fussiness, and there might be associated diaper rash. So there also the Candida can be seen. So these are the, these generally, these two things occur together. So how do we treat it? Treat the mother and baby simultaneously. If we do not treat both simultaneously, then the infection can move from one to other. However, again, recently this point is debated, whether the baby can give Candida to mother and mother to baby. This point is again a debatable point. Some say that local nystatin can be applied to the nipple and areola, and clotrimazole to the baby's mouth. Here again, some people say that don't apply anything locally to the breast, but in the baby's mouth, we can apply clotrimazole. However, one important thing is gentian violet should never be applied to nipple. It causes tissue damage and it worsens the problems. Most of the time, oral fluconazole is also needed. Just local treatment generally does not work. And items that come in contact either with the baby's mouth or with the mother's breast have to be cleaned properly, because that will also carry the Candida. So here we have discussed how the flat or inverted nipples can cause problems, and what to do with that, with what to do with the cracked nipples, and what to do with the Candida. But there are many other causes also of nipple pain. These will include some dermatologic conditions like eczema, psoriasis, some infections, bacterial, viral infections like herpes simplex, herpes zoster. There can be vasospasm and some other pain syndromes, and breast drainage problems, which can lead to plugged ducts and oversupply, and also the infection that we have all discussed just before. So these are all the other causes of nipple pain, which we cannot discuss today because of lack of time. And I think I have done justice to the topic that I have been allotted, and I have finished within time. Thank you very much for the patient listening.
Thank you, sir, for your gentle and very informative talk. And over to the chairpersons for your valuable comments, ma'am.
Thank you very much, sir, for in-depth, insight into the subject, which is very common and very important to understand, the cracked nipple, inverted nipple, and candidiasis of the nipple. And you covered right from embryology to problems associated with the breast piercing to diagnosing, clarity of candidiasis, and also the importance of treating the baby as well as mother for the oral thrush in the baby. So even as neonatologists, I think we should also make it a point to examine mother's nipple when we diagnose oral thrush in the baby, and also help the mother with the conditioning. So thank you very much, sir. It was a very great learning experience.
Ma'am, there is a question they want to know the difference between mastitis and breast. Take it later because it was already explained very well in the presentation. Should we
Yes.
take it later or now?
Yes, I think it was really explained very well during Sushma
All right.
ma'am's
Fine, ma'am.
lecture.
Fine.
Yeah.
So we move on to our next session, which is on kangaroo mother care, feeding of low birth weight babies and premature babies, including trophic feeding and colostrum collection. And for these, I invite and welcome the Honorable Chairpersons, Dr. Girija Wag, Madam, who is FOGSI Vice President 2024. She is Professor and Head of Department of OB-GYN, Bharati Vidyapeeth Medical College Hospital, Pune. And she has been faculty professor at OGASH, International Experts General Coordinator, chairperson of Medical Disorders in Pregnancy Committee, FOGSI, and member of the governing council of ICOG. She's received the Anandi Bai Joshi Award for Excellence in Medical Services. Welcome, ma'am. Then we have, I'd like to invite Honorable Dr. Alka Pandey, ma'am, who's Professor, Department of OB-GYN Narayan Medical College, Saharsa, and she's ex-associate professor, Department of OB-GYN, PMCH Patna. She was vice president FOGSI 22-23, organizing chairperson of FOGSI Vice President Conference. And then we invite Dr. Rajat Mohanty, sir, who was Vice President FOGSI 2019, Chairperson Midlife Management Committee FOGSI, and the Governing Council member of the ICOG. So over to you, sir, to invite our speaker, Professor Shashi Vani, madam. Dr. Alka Pandey, madam, could you invite Dr. Shashi Vani?
Yes, yes. Thank you so much for giving me this opportunity. And Professor Shashi Vani is Emeritus Professor of Pediatrics, PS Medical College, retired senior professor and HOD. And she has organized 2 international and 8 national KMC conferences and more than 50 training programs of KMCFI. Areas of special interest are newborn care, KMC, breastfeeding, ORS, immunizations, NRP, thalassemia, etc. She has many publications, international and national training programs, workshops in India and other countries. And she's past president of National Neonatology Forum, India, Indian Academy of Pediatrics, Gujarat State and Ahmedabad city chapters, founder president of Gujarat NNF, national vice president of ISOPARB, winner of several awards, including Lifetime Achievement Award of NNF AOP Gujarat. Then she has been invited for many orations, and now we invite Professor Shashi Vani to give her lecture.
Thank you very much for giving me this opportunity. And I'm mainly taking up the role of obstetricians in promotion of kangaroo mother care as a whole, and the specific points we will take up in a little while. And first of all, we convey our greetings from the Kangaroo Mother Care Foundation of India. Now, we are really happy to note that Kangaroo Mother Care is gradually making some inroads even amongst our colleagues in the fraternity of obstetrics. And here I would like to start with the thing that our foundation has been started with the main mission statement that mother's chest is the best place for the newborn care, mother's milk is the best food for the newborn, and zero separation of mother and her baby is one of the important emerging concepts which we have to understand. And our vision is to make sure that KMC should be a part of the routine care of the newborns. And it has got special benefits for low birth weight infants, including preterm babies. And it is not to be considered something special, something different. Incubators, warmers should be used only when kangaroo mother care is not possible. Originally, this care started as a substitute for incubators. Wherever incubators were not available, how to provide warmth to the baby. And then they found out this mother's body warmth can be a great help to the baby. But subsequently, they have found out that there are so many other benefits. And now, kangaroo mother care is considered as a method of comprehensive care of the newborns and not just a poor man's incubator. So that is the concept I wanted to convey here. And one other important aspect is kangaroo mother care. The name itself includes that mother component which has been included. That doesn't mean it has to be done. This care has to be provided only by the mother. On the contrary, it implies that kangaroo mother care includes breast milk feeding, and breast milk only mother can produce. So the importance of mother is included in the statement of kangaroo mother care. And that is why the terminology conventionally accepted as kangaroo mother care. Whether the care is given by the father or other family members or anybody, but still we retain the main terminology as kangaroo mother care. Now here, so first of all, we find still people have not fully understood kangaroo mother care. Just holding the baby on mother's chest on direct skin-to-skin contact, only that as majority of the people consider as a kangaroo mother care. But today we find that it has an expanded connotation. So kangaroo mother care is now being practiced almost everywhere in every situation, and we will come to that gradually. So I am taking this opportunity to give a broad introduction about kangaroo mother care here, and finally request our obstetric colleagues to take up much more proactive role, leadership role in promotion of kangaroo mother care. So it is described as a low cost but high skill and high impact humane method of holding the newborn directly in skin-to-skin contact on mother's chest. Because commonly the word is used skin-to-skin contact, but it has to be specified that skin-to-skin contact on mother's chest in between her breasts without any layers of clothing in between the baby and the mother. And the baby is slightly extended neck in as much vertical position as possible. And baby and mother, both of them are covered together from above. So that is the description of kangaroo mother care. Actually, it is better described as a loving body hug between the mother and her baby than mere superficial skin-to-skin touch. It conveys so many of the benefits of kangaroo mother care if you put that concept of it is a loving body hug. In Hindi, generally we used to say mamta ki jappi. So rather than saying mere superficial skin-to-skin touch, it is the loving body hug where all the emotions and the love of the mother is transmitted to the baby in such a way that baby gets so many benefits. And this care can be given to all the babies, but it is especially beneficial for the low birth weight babies, particularly for the birth weight less than 2000 grams. Now, this 2000 gram, earlier we said because in India, we had a large, huge chunk of babies less than 2500 grams. And all the babies, if we wanted to provide the services, it would be very difficult. So some priority has to be decided. So accordingly, the cutout point was decided for 2000 gram. But now it is expanded to include all the babies who are low birth weight babies, that is, who have got less than 2500 grams. And the WHO has recognized its importance, and it has given the definition that it is to hold the baby in direct skin-to-skin contact on mother's chest in between her breasts as early as possible, as frequently as possible, and as long as possible. And it should be combined with exclusive breast milk feeding, planned early discharge, and scheduled regular follow-up, including the follow-up for the neurodevelopment. Here, kindly note, we are using the word breast milk feeding because kangaroo mother care has got particular significance for the care of the preterm and low birth weight babies. Many of these babies cannot start directly on breastfeeding to begin with, and in that case, we have to express the breast milk and then give these babies through suitable modes. So that is why we use the word breast milk feeding than only mentioning breastfeeding. So with this understand, just a brief introduction, we want to impress why we need to promote kangaroo mother care in India. You know, we have a huge newborn care challenge in India. Just to put briefly, we have got the highest number of births, more than 270 lakhs per year, highest number of neonatal deaths, highest incidence of low birth weight babies, highest incidence of preterm births, highest number of stillbirths, and so on. And there are wide disparities, urban, rural, rich, poor, boy, girl, and so many regional factors. With this huge challenge, of course, in recent years, we have been making a lot of efforts. There have been some improvements, but still our global ranking as #1 country with the highest neonatal burden is still continuing. So what should be done in such situation? In developing countries like India, with very high newborn mortality, experts have agreed that when our public health systems are still not so very strong, inadequate facilities are there, simple interventions like breastfeeding promotion, kangaroo mother care, hand washing, and avoiding some of the harmful traditional practices, they all go a long way in saving thousands of newborns from dying due to easily avoidable as well as treatable causes, provided at least 90% coverage is achieved. So that is a very important statement. This has come up almost since 2005 or even earlier also we understood that. And we have been trying to promote breast milk feeding, breastfeeding also, but still we know with all these more than 50 years of experience, we have barely reached at national level 40 to 50% early initiation of breastfeeding rates and barely 50 to 60 or 60 to 70% of exclusive breastfeeding rate and long way to go. So that is the main point. So we need to promote these simple interventions. And these simple interventions, what is the potential they have to reduce the neonatal mortality at 90% of coverage? They have already mentioned that breastfeeding has got the highest level 5 evidence of preventing almost 55 to 87% of the neonatal preventable causes of mortality. And similarly, kangaroo mother care, through its multiple interventions like preventing and management of hypothermia, as well as reducing infections, it has also got a very high potential. So with this background, naturally, we have to promote kangaroo mother care. And this, we have found that almost since last 30 years, we are making efforts, but only after almost 20 years, Government of India has endorsed that kangaroo mother care is definitely a life-saving intervention for all our newborn babies, particularly low birth weight and preterm babies. And it has been now included in the National Health Policy also. and it is one of the core interventions in India Newborn Action Plan as well as Sustainable Development Goals. So again, I am saying that this is a very important intervention and it has to be given much more attention than we are taking today. Yesterday, I was really very happy to note that many of our obstetric colleagues were giving very good inputs for the promotion of kangaroo mother care and what best efforts they are doing. But the same efforts, it should not be limited to a handful of them. It should spread everywhere. So that is why we want to take your help also here. And what is the coverage here? That we want to reach up to 90% by 2030, but in public sector, barely there is a report of almost about 50% reach in SNCUs, and in public, we do not have any information about the private sector, and so many of the efforts through the professional bodies are also required now. I won't go in detail here, but this is just to impress upon you how important is kangaroo mother care for our country. And now, recently, WHO has again endorsed the importance of kangaroo mother care, particularly for the care of preterm and low birth weight infants. And they have made a statement that all the preterm and low birth weight babies should receive routine care of kangaroo mother care without waiting for anyone to advise them. And not only they should receive it, but it should be given both at the facilities or hospitals also, and now it can be started at homes also, and it should be given for minimum of 8 hours per day and can be given almost up to 24 hours a day also. It has got very high certainty evidence, and this has to be taken note of by everybody very seriously. Another important WHO study has proved now that earlier we were advising kangaroo mother care only for the stable babies who did not have much acute problems. But then by the time you wait for the babies to become stable, we are losing many babies in the first 24 to 48 hours itself. So then they introduced care of the babies, immediate kangaroo mother care or early kangaroo mother care as early as possible within the first 24 hours itself, even for the very small and sick babies also. And this experiment done in the 5 international stages in multi-country study has given such beautiful results that they had to stop the study in between because the results were very, very encouraging. So now they have recommended that IKMC or immediate KMC should be started as early as possible after birth for even small and sick newborns also. And this has the potential of saving almost 150,000 more babies globally. So this is the significance given here. And just to now go for a few basics, that kangaroo mother care, as I already said, holding the baby on direct skin-to-skin contact on mother's chest is just one component. Exclusive breast milk feeding promotion, that is the next important component, and planned early discharge and regular follow-up is third most important component. So all the 3 components should be there to explain the kangaroo mother care. So holding the baby on mother's chest, continuing breastfeeding even during the kangaroo care, properly planned discharge of these babies, and subsequently regular follow-up of these babies, and post-discharge continuation of home-based kangaroo mother care. Because as I said, in the definition itself, we have put the word planned early discharge. That is, we do not request the parents with the babies to stay in the hospital till the baby reaches at least 2,500 grams, which is the ideal requirement. But with kangaroo mother care, if we have built up the competence and the compliance of the mother, we are able to discharge them at home earlier They can continue home-based kangaroo mother care, come for regular follow-up, and reassure for the well-being of the baby. And for all these things, the mother to carry out kangaroo mother care, there a lot of family support is also required. And all these, again, support, it should start from the hospitals itself, and then it should continue at home. Hospital, mainly, they should be properly treated well, give them respectful treatment in the hospital. And one of the important deterrent for the mothers to come to the hospital, they have noticed, is the behavior of the staff. So that should improve. They should make them feel that they are at home-like environment in the hospital, provide all the facilities required. I won't go in details, but including toilet facilities, food facilities, visitors, and so many other things are required for the person to stay in the hospital comfortably and continue with the baby care and the breastfeeding satisfactorily. And the same support should be continued at home also. So these are all the requirements in the kangaroo mother care. Now there are several benefits noted. I won't go in the details, but we will notice that overall it reduces the morbidity and the mortality rates, and particularly mortality in the low birth weight and preterm babies, which is a very, very important thing. It improves breastfeeding, reduces infection, reduces hypothermia, reduces the chances of hypoglycemia, and so many things. Mothers also get benefit, and mainly mothers' milk secretion increases. Mother is able to successfully breastfeed her baby. That increases her self-esteem. Bonding is more, and postpartum depression, they are much less. And most important thing is confidence and competence for the care of a very small baby is much more in the baby mothers who are given proper directions for the kangaroo mother care. Families also get benefit. Mainly the cost is reduced and family involvement in the care is included. Hospitals also benefit because nursing care is also minimum and cost of the baby care is much less because the hospitalization is also much less. Community also benefits, and harmful traditional cultural practices and beliefs are much less, and community involvement of newborn care is increased, and overall there are many benefits at the country level also. For the time limit, I'm passing on quickly, and there has to be a few quick tips about the kangaroo position, baby. Very often the word kangaroo mother care and kangaroo position are interchangeably used. So first and most important thing is how to hold the baby properly in the kangaroo position. So just a few quick tips. So this is the position which WHO has advised, that baby is held in between the mother's breast and baby's head is turned to one side in such a way that mother and baby should be able to have eye-to-eye contact, and mother should have a nurturing aspect to the baby care here. And of course, the baby's hands are flexed above the breast and frog-like position below the breast. And how to do it? Of course, hand washing, the proper techniques have to be told. Mother is to be prepared and direct, she has to put the baby on direct skin-to-skin contact. The baby has to be prepared that at the most the baby can have a diaper and then cap on the head, because almost 10% of the body heat is lost from the head. So that has to be realized. And if available, a kangaroo bag can be put, and then the baby is put on mother's chest directly on skin-to-skin contact. And then the mother is given all possible comforts, and mother to carry out this care for a longer time. Before starting kangaroo mother care, she has to be counseled well, oriented well, and not only her, with her family members also. And then, if required, mother should be able to get all the family support, not only for the multiple births, even for the same baby. The longer duration the kangaroo mother care given, the more benefits are there. So mother can hand over the baby to another family member for some time when she is tired or she has to take break for some reason. So some alternate kangaroo care providers from the family members or even from the friends, they are required. And then, of course, relaxation during KMC to be provided, all the facilities so that she can continue for a longer time. Place for kangaroo mother care has to be chosen carefully where the mother is not put in a dungeon-like small dark room, but she has given a pleasant atmosphere. And now there is a big improvement occurring. Earlier, we were giving intermittent kangaroo care for the babies who are on oxygen, IV fluids, and sick babies also. But now the further leap is the mothers are being admitted in the NICU itself. They are given the bed in the NICU itself so that they can stay there and they can provide kangaroo mother care as long as possible for their babies. And sometimes their family members are also allowed and they can also provide. And this is the newer development which is coming up, which we call it as mother and newborn care unit. Actually, it is mother in NICUs. And there the role of obstetricians is they have to come in the NICUs to examine these mothers and properly check up these mothers also and advise for these people. So this concept is now coming up that even for the sick babies and small babies within the NICU itself, we are allowing the mothers to provide this. And that is a very, very important development which is coming up. And Government of India is also now planning to give extended facilities and budget for these things. So this is another important concept. And now step down unit, when the babies are settled, mothers are still made to stay in the ward itself to provide more care for these babies, and they can allow family members also. Duration. Every time when you hold the baby on kangaroo care, minimum of continuous 1 hour the baby has to be there. Only then the baby can complete a good sleep cycle, and that benefits for the brain development of the child. That is a very thing. Otherwise, sometimes you hold the baby for 10 minutes, 20 minutes, again take it back. That frequent handling is very stressful to the baby, and minimum of continuous 1 hour. To achieve that effective 1 hour, we in practice advise for minimum of 90 minutes, so that at least 60 minutes we are assured that the baby is getting. And one session mother can hold as long as she is comfortable, say for 2 hours, 3 hours also. It's not necessary that at 1.5 hours you have to stop. And then cumulatively you calculate for the 24 hours, and it should not be less than 8 hours within 24 hours. So that is a very important aspect. And discharge also, you decide the criteria. The mother must be confident in continuing the similar care at home. Baby must be satisfactorily gaining weight. Oral feeds, either in the form of cup feeding, palade feeding, or even NG feeding also, if they are staying nearby, they can manage. And that express breast milk to be given that. And all these criteria are set, and then they are discharged home. While discharging also, they are sent in the kangaroo position, and then when to stop kangaroo mother care. Temporarily we stop when you want to routinely check up the baby or change the diaper or sponge the baby, or whenever any other help is not available. But total stopping is decided by the baby's behavior. We don't decide. Generally, we say when the baby is around 2,500 grams weight or around 40 weeks of gestational age, that is the time. Around that time, babies generally don't stay much longer in the kangaroo care. Every time you try to put them on kangaroo care, the babies start wriggling out, and that is the indication to wean these babies from kangaroo mother care. So it is the baby which decides, and then we should have regular follow-up of these babies for checkup, not only for their breastfeeding, growth, immunizations, but also for the neurological development. And then, of course, what is the scope? It is not only in the hospitals you practice, but even in the cesarean babies also, you can start kangaroo mother care. Even in the sick babies who are on IV lines, oxygen, CPAP, And even on mechanical ventilators also, depending on the expertise of the staff members and the experiences, they are now able to put them on these babies also on kangaroo care. And they have found out that once you put the baby on kangaroo care, the requirement of oxygen is much less. They can be weaned from the ventilation also much earlier, and there are so many benefits. And this early skin-to-skin contact for the newborns, even for the term babies, it's helpful. I'll give that example later on. And during transport of the newborns, we do not have ideal newborn transport system everywhere. The best system is to put the baby on direct skin-to-skin contact on mother or any other helper who can available and transport the newborn babies. Thereby, you are assuring that the baby remains warm throughout and the baby is having a very secure feeling, stable feeling, and the physiological alterations are not much, and it is a very safe method. In some of the countries now, they have made kangaroo transport almost an compulsory thing for the newborn transport. They have realized that in many situations, it is even better than the transport incubators. So this is the importance we should remember. And another important part is when you have to do some painful procedures like heel prick or give injection vitamin K soon after birth or so many other interventions, ideal will be to put the baby on mother's chest for at least 10-15 minutes and then do these interventions. Baby feels the pain much less. So mild to moderate painful procedures can be done without any medications. So like in transport, you can do KMC, you can do home situations, you can promote kangaroo mother care, and like that there is a lot of things. Now, another important concept here is now zero separation. That is, as far as possible, right from birth, you do not try to separate the baby and mother. That is coming up in a big way. That now we are not only aiming for the mere survival of the babies, but we want an overall well-being, and the baby should be thriving well and grow up well with the full potential of their intelligence and with a love and good quality of life. What now we call it as a nurturing care of the newborns. And nurturing care of the child, it starts with the nurturing care of the newborns. As we have put rightly, Dr. Meherban Singh has mentioned, the survival of the newborn, somehow we survive these preterm babies, low birth weight babies, and then they land up with all the developmental issues and problems. That is not the goal now. Survival of the newborn should be an asset and not a liability to the society and nation. And for that, this concept of zero separation is very helpful. And for that, kangaroo mother care is one of the very, very important intervention. So that is the point we have to realize here. And currently our method of care involves small and sick babies and sometimes even normal babies. Suppose they are cesarean delivered, meconium aspiration, or some transient tachypnea of newborn, or even such situation also. We try to separate the babies, keep them under warmer for observation and keep the mother separately. We think that will do good for the baby and the mother. On the contrary, now they have found out that this separation is not justified and there is a very strong scientific basis for explaining this zero separation. That is not to separate mother and baby. Even in the COVID era also, we have recommended not to separate them because the benefits of keeping the mother and baby together were much more than separating them. And then they have found out that in our anxiety to save these babies, many times we keep them under all the equipment and machine. But in all these things, that loving attachment with the mother is missing, and that proves disadvantages. So yes, In some of the dire situations when we have to separate the babies, yes, but do it for the minimum time. Otherwise, whatever possible methods we can do, even by keeping the baby on mother's chest. Yesterday also, Dr. Gangal has beautifully shown that some of the interventions, even the basic resuscitation, everything can be done keeping the baby on mother's abdomen or mother's chest. So that is the best approach. Try to minimize the separation of the baby and mother. In our anxiety to give the best treatment, we always give, means womb-like treatment, we put the baby in nesting and all those things. But if you continue to give the baby the kangaroo mother care, this may not be required. So preterm care aims for a womb-like care, and we try to provide the technology-based NICU care, which is a poor substitute for womb. And this is not only there, this helps for the optimum neuroprotection and neurodevelopment of the baby. That has to be remembered. I'm just quickly passing through these things. So ideally, as I already mentioned, use the separation of the baby, use of incubator, warmers, etc. as minimum as possible. You should be able to take your own audit in the ward and find out whether you could have minimized this separation. And what happens to the separation? There is a positive stress. When the baby is separated from the mother, for a short while, if it is stress is there, some discomfort may be there, but this stress is sometimes required for the development of the child, accepted. But when the separation is for a longer time, these stress responses, they disrupt the brain architecture which is developing. All the synaptic junctions which are developing, they are not properly developing, and that affects the baby. But if this stress factor, like precipitating factor, absence of mother for a few hours, or some painful procedures, harsh lighting, loud noise, all the developmentally harmful atmosphere, if they are there, feeding difficulties are there, and there is no diurnal changes, all these will affect the baby. But if it is short term, somehow the things are recoverable. It is potentially damaging, but at least some recovery is possible. But if in terms of very extreme preterm babies or very low birth weight babies with multiple complications, we try to separate the mother and baby for a longer time. The stress is much longer and it becomes a chronic stress and it affects the neurodevelopment very much. I won't go in detail, but it may have a long time individual effect on the physical and mental health of the baby. So in short, we have to see that whatever we do the minimum separation of the babies. And these separated babies cry. Even in the neonatal resuscitation also, earlier we used to believe that we should make the baby cry, have a lusty cry, but nowadays that science is changing. So modern neuroscience does not approve separated babies cry, that distress cry, because during that cry, there is reduced growth hormone and increased cortisol secretion. And that increased cortisol secretion, it enables survival at the cost of extra energy expenditure. This is one of the important factors for high incidence of hypoglycemia, because there is a disruption between demand and supply. And that also is harmful to the baby's brain growth. And this factor. So in short, I'm just summarizing that zero separation is biologically normal and improves the quality of survival. And we should keep the babies as much as possible on mother's chest. And there the baby feels safe, brain calms, the body calms, mother also feels safe, and there are so many benefits. All the 5 senses of the babies are satisfied there, and it helps in the multimodal stimulation of the synaptogenesis and ultimately brain development. So skin-to-skin contact combined with the breast milk feeding, they all help for the ultimate well-thriving and well-being of the baby. and the nurturing care of the baby, and very helpful. So, kangaroo care in the form of developmentally supportive care is one of the best safe method, and the brain is working in a very safe mode, and it prevents increased pain, prevents intensive stress, and prevents depression in the mother due to separation and other reasons, and it is helpful in many ways. So now, even in the Western world, advanced centers like Sweden and other places also, they have approved that the new place for care for the premature infant is the chest of his or her parents. So it is not now anymore only a poor man's substitute for incubator, but it is a method of comprehensive newborn care with all the factors of developmentally supportive care. Recently, WHO is promoting nurturing care for the newborns and the children, and the developmentally supportive care. And the nurturing care has the following components: good health, adequate nutrition, security and safety, responsive care, and opportunities for early learning. All these are provided through kangaroo mother care. Similarly, developmentally supportive care has a lot of inputs for the early child development. It lays a strong foundation for the child development, and it also includes a healing environment where the noises are much less, the bright light is much less, the harmful effects are much less. Partnering with the families. The families are involved in the care of the babies as much as possible. They are not kept away from the babies. Positioning and handling, safeguarding the sleep, minimizing stress and pain, protecting the sleep, optimizing the nutrition, including the breast milk. All these are achieved through KMC much better. So that is the point we have to promote now. So think of, so what is the clinical application of this information? Think of all possible such situations in your NICU. For obstetrician, I will say, think of all such situations, even in your delivery rooms. And now you are also invited to the NICUs where the mothers will be there. And think of all situations where you can keep the mother and baby together. Suppose a baby is receiving minimum oxygen. That the baby can receive while the baby is on mother's chest. Baby is receiving IV fluids. Yes, that is possible. Phototherapy. Yes, that is possible. Baby is receiving heel prick, vitamin K injection, or baby is having ultrasonography. All that is possible when you keep the baby on mother's chest. So think of all such situations, and we create a chain of zero separation. So starting right from the birth. So keep the baby on mother's abdomen even before cutting the cord. Yesterday also it was shown, and I was really happy that this concept is now coming up. So even before cutting the cord, even before drying, just put the baby directly on mother's abdomen as soon as the baby is delivered outside. And then as we are waiting for the cord to cut, you start drying the baby, and then gradually shift the baby to mother's chest, where the breast crawl can be promoted for all the term babies. And for the small babies, you can put them as closer to possible as possible to the mother's breast. Some people ask us, Madam, why allow the baby to crawl? Why not put directly on the mother's breast? No. As far as the baby is possible to crawl, let it have the crawl, because that stimulation on the skin, that will produce more oxytocin, and that will be helpful for even breast milk secretion and so many other benefits. So what are the benefits? This early skin-to-skin contact and the breast milk production and the breastfeeding, they are really interrelated. Now strongly recommended by WHO, American Academy of Pediatrics, and all the others also. So this is to be done, and that will successfully continue supply of mother's own milk, early breast crawl, early easy latching, and so many advantages will be there. And all these together, they lay a strong foundation for the early child development and better cognitive and neurodevelopment and behavior of the baby. And they have got other advantages also. They stabilize the babies much faster. The physiological stabilization of heart rate, respiration is achieved faster. Babies become much easily calmer, not excessive crying. They are relaxed. The early baby mother bonding occurs, and that regulates the baby's body temperature also, reduces the chances of hypoglycemia, as I told you earlier, improves the blood oxygen level. It minimizes the apneic attack. It minimizes the requirement of oxygen and less release of cortisol and stress hormone. And all these cumulatively again help in improving the quality of breast milk feeding. And there are many other benefits, immediate and long term. And important thing is, this early skin to skin contact just for a few minutes is not enough. It should be kept there, the baby should be kept there at least for 1 hour minimum. Many people argue, oh, our labor rooms are very crowded, we have got so many deliveries. You have to have this provision. So either you keep the baby on mother's chest and transfer them to another waiting room or whichever place you have with the baby. So that do not separate the baby and mother. Keep the baby there at least for 1 hour. And in case of preterm babies, they even recommend for continuous at least for 2 hours. And that has got several cumulative advantages we have to remember. So if this immediate skin to skin contact on mother's chest, just for a few minutes, say 10 minutes, 15 minutes, it is not of much help. Yes, it does help, but to get all the benefits, it has to be there at least for 1 hour. So that short-term skin to skin contact on mother's chest should not be confused with kangaroo mother care. To call it or label it as a kangaroo mother care, at least it must be there for 1 hour with some efforts for breast milk feeding. So in this case, when the babies are very extremely preterm babies, as yesterday also it was shown, you can express colostrum, aspirate by syringe, and put these few drops of syringe in the baby's mouth. That will help for the colostrum swabbing also, and it initiates that. And this syringe feeding also for these babies is very helpful. So that we have to remember. So we can start colostrum feeding right from that stage. And once the baby is a little more mature, even non-nutritive sucking also can be promoted. Same thing can be done now, as we say, I am very happy to learn that even yesterday also, people are supporting that we should be able to give early skin to skin contact on mother's chest even in cesarean cases. Maybe the position may be different. Rather than holding the baby vertically in between the breasts, you can hold them horizontally or you can put them reversibly. And for that, some dedicated staff may be there, or you can train one of the family members to come in the operation room and help you. And I have seen this happening in many centers abroad where they keep the screen, the operation is going on the other side, and the nurse or the family members, they attend to the baby from this side as soon as the delivery, even before completing the operation. And that helps even in the early initiation of the breastfeeding, early skin to skin contact, and the zero separation and all its benefits. Similarly, even the twins with oxygen therapy also can be kept. Sick babies on CPAP also be kept. As I said, even the procedures can be done keeping the baby on mother's chest. So do not separate the baby and mother. And for that, you have to train your family. First of all, you have to train your staff. You have to convince them and then establish all the protocols in conveyance with your anesthetic colleagues and so many things. Develop your protocols. Once you appreciate that it is a much needed intervention, you will try to find out your own improvisations and facilities how to do about it. So I am not going the detail, but it is a very much needed thing even in the COVID era. And so one word, it is huge disservice for the mothers and their newborns who are separated and please try to avoid as much as possible. Now, KMC and breastfeeding, the other aspect I'm saying, I already told you about the early initiation of breastfeeding. Yesterday also, there was a beautiful
Excuse me, ma'am.
presentation
Ma'am,
on early
sorry.
initiation of breastfeeding.
Yes, ma'am. Sorry to interrupt you, ma'am. The time is over, though it is really.
Just 2 minutes, that's all.
Okay, ma'am.
I won't take much. So breastfeeding promotion, all that we have already said. One important thing is, even when expressing the breast milk, hold the baby on mother's chest. And even at home also, you can train them. So finally, what is the role? Now, having known kangaroo mother care, the most important thing is, now we request our colleagues from the obstetrics to join us like leaders. You are the first one to start antenatal care, and you have interaction with the mothers for a long time. And naturally, you have got the best confidence from them. So you should initiate. And all your antenatal counseling sessions, please mention kangaroo mother care. So that is one thing, because if mother is ready to accept kangaroo mother care soon after birth, it doesn't come to her as a new intervention, something different which she has not been told. She is mentally prepared for that. And a family participatory care approach comes. So that is one important thing, that immediate skin-to-skin contact, which I said, try to promote it everywhere. So that is another important thing. Zero separation concept. Even in cesarean cases, how you can improve. Neo-BFHI includes kangaroo mother care. It is not just mere skin-to-skin contact. It is the kangaroo mother care. That is prolonged skin-to-skin contact of minimum of 1 hour with all its benefit. Promote kangaroo mother care during transport as a pain relief measure, even in home-based KMC. And remember, in cities, there is a pediatrician or a neonatologist helping you. In many other places, in the smaller places, there are no independent pediatricians still available for all the babies. You are the neonatologist, you are the pediatrician, and even the birth attendants, they themselves have to take care of or advise for the newborn care. So you have to take up this responsibility and promote this concept. So nurturing care concept, mother and newborn care units, and family participatory care, all that. And just as we have developed 10 steps for successful breastfeeding, BFHI, we have to develop 10 steps for successful kangaroo mother care. I won't go in detail. Thank you very much for giving me this opportunity. And once again, I plead with all our obstetric colleagues, please join us in promoting kangaroo mother care. You are equally the leaders like us, and baby's care is dependent on you. Mother and newborn care, we have to go hand in hand. Thank you very much.
Thank you, madam. It was a wonderful lecture, and you have explained everything so well. I don't think there'll be much questions. So over to the organizers.
So thank you, ma'am. It was really indeed a very amazing and unique presentation, madam. Thank you so much. And I especially like the one in which the mother is made a part of the NICU also. And everybody is now desperately waiting for the MCQ test link, post-test.
Let's post the link.
Over to you, sir. Over to you.
Let's post the link. And
Yes, sir.
madam, your commitment to the cause of KMC is commendable and contagious, and we all would want to follow. And the first hurdle is the obstetrician. So the fact that 130 people have come forward for this program means that they are ready to change, and I think that's a very positive step. I'm sure many more people will join in. And once the obstetrician is convinced, the rest will follow. Thank you very much, madam, for the talk.
So
Thank you very much. And now we'll
pediatricians are really, really very much ready for all this, sir. And in fact, we also find it very challenging sometimes to explain to the pediatrician, to the staff and all. So I think it works both ways. Challenges are everywhere, and we just have to overcome them. That is the main idea.
Yes, obstetrician is the captain of the ship.
Yes,
If
sir.
you are convinced, the staff will get convinced. The staff get convinced, probably will pass it on to the patients. And once the patients start asking for it, the society will gradually change. So, there are a lot of stumbling blocks, but it's best to take one step at a time. So we've taken that first step, and I'm very happy that ICOG has done this course, designed this course on breastfeeding. The test is on. So a big job done. If we can share the correct answers, we will just go through the answers fast. We are sorry that we overshot the time by around 15 minutes. We will just go through the question answer. We won't discuss any of these together. So the first question is, breast and nipple examination is necessary during the antenatal period? False. What is the appropriate way to address common breastfeeding challenges in the antenatal counseling? It's by providing information on techniques and resources for breastfeeding and help overcoming all challenges as well. What should be the primary focus of antenatal breastfeeding counseling? It's teaching techniques, importance, and the benefits of breastfeeding. So it's basically counseling. How often does a newborn how often should a newborn be breastfed in the first 2 weeks of life? So every 2 hours. So what we say is that every 2 hours you put the baby to the breast. If it wants to take, it will take. And once the breast is, then it's to be done on demand. Now, for a good attachment, which part of the breast should be inside the baby's mouth? So maximum part of the areola, especially the lower part. For premature babies, which position is best? Cross cradle or modified cradle? 7. While breastfeeding, which statement is wrong? Mother should sit with support, mother should interact with the baby, mother should not lie down and feed, or mother should hold the baby in seat. The correct answer is mother should not lie down and feed. All the other statements are true. Which reflex helps the baby the most while breastfeeding? Rooting. Now, why should we promote KMC in India? Because our burden of low birth babies is very high and facilities for their care are not enough. Now, in kangaroo mother care for the newborn includes, show me the answers. Direct skin-to-skin contact of mother's chest, exclusive breast milk feeding, as well as planned early discharge and regular follow-up. What are the benefits of KMC to the newborn? All of the above. The answer is D. The role of the obstetrician in promoting KMC includes screening for all except screening for ROP and hearing in the newborn babies. That is the job of the pediatrician. You can always tell by looking at the nipple whether it is normal, flat, or inverted. True or false? It is false. Is it the teat? It is the teat made of nipple and breast tissue that the baby suckles on. Hence, the babies can usually breastfeed even if the nipple is flat or inverted. True or false? True. Preparation and treatment of nipples in antenatal period is important and effective. False. Show me the answer. What is the most important treatment of cracked nipples? Show me the answer. ICOG? Yeah. It is most important treatment for cracked nipple is correction of position and latching. This mother says her breast feels very full and hard. Her 4-day-old baby cannot effectively latch because the breast is so full. What would your first suggestion be? Hand express to soften the areola and nipple so that she can breastfeed. A pregnant woman had surgery to drain a breast abscess during a previous lactation and asks about consequences to breastfeeding this time. Which aspect of the surgery is most likely to negatively affect the breastfeeding? Location of the incision relative to milk ducts and nerves, because a curved incision at the areola will cut the ducts and the nerves. Breastfeeding mother calls to report waking up with a high fever, chills, and flu-like aches. Her left breast is red and painful, which is the most likely condition causing these symptoms. Mastitis. Next. Breastfeeding mother complains of a lump in her breast. Which characteristic of the lump is most likely to be dangerous and require medical evaluation? The lump does not change size before and after the baby feeds. So that lump is dangerous. I hope all of you have done well. I'm sorry we have extended the time, but the sessions have been very, very good. So over 3 days, first day we spoke about steps 4, 5, 6, 7, 8, 9. Today we spoke about step 2, 3, 5, and 7. And tomorrow we'll cover step 1 and the additional informations. Thank you very much for being with us. Divya, you can, Dr. Divya, you can give the vote of thanks.
So thank you to all the conveners for giving us such a wonderful academic feast and something so new and so different and unique for all of us obstetricians. So we are really thankful, and we're thankful to FOGSI and ICOG. And thank you to the speakers and to the chairpersons who've taken all the time and made all the effort to be with us and to teach us. And last but not the least, thanks to all the delegates who stayed with us to do the test. And see you tomorrow evening once again for the last.
And thank you, Dr. Divya, for being there all the time.
Thank you, sir. My pleasure always.
All right. Thank you so much. We can close the session.